Hello, hello, hello. Can you hear me? That is
Yes,
okay. Ana ji ko?
yes.
Okay, to shi ke. Good morning.
Morning, sir.
Welcome. I think we can start. We have a lot to say. Okay, good morning, everyone. We are welcome to this session of Neuro Workshop series. Am I audible? Hello?
Yes, you are audible, sir.
Okay, okay.
You're audible.
And the screen is showing?
Yes, it's showing.
Okay. So the workshops are organized this time around to be more of a hands-on or in practical base. If you followed us previous years, you could see that we try to do or we concentrate more of a theory. But this time around, we want to be a little bit more specific and try to be more practical based in terms of the workshops and the lectures to be delivered. So for this month of February is going to be a neuro session where we will be having basically under neuro we will just pick an assessment of balance in this month, and the balance is going to be related to stroke and Parkinson's disease being one of the major conditions or disorders we manage day to day in our clinics. So we are going to run it in such a way that we have the discussion about the balance assessment, postural assessments, and then related to lower extremity today. Then the next week will be related to the trunk, and then we'll have a day that will try to practicalize what we discussed across these weeks. And then one of the major aim is that when we discuss techniques or skills in these presentations, then individuals are expected to go and put to practice those type of techniques or skills discussed in their own clinics so that we can have feedback later during the hands-on of the challenges or the advantages and disadvantages, what are the experiences an individual face, anything that individual can raise which could be of benefit, so that individual could share with us, and then we discussed and find solutions where there is a need. So this is the pattern, how it's going to work. So this week or today is going to be solely on posture and balance, and it's going to be on two sessions. I'm going to take the first session, which is more related to posture and a little bit of balance. Then the second session will be on majorly balance. So without wasting time, I think we can go into the session. So the title is Postural Control and Balance Confidence in Stroke and Parkinson's Disease. So the discussion, because I try to avoid the use of lecture or presentation, it's supposed to be more of a discussion. So the discussion is going to be centered towards looking at what we want to achieve at the end of the day. Some things we need to put into consideration and try to think what we do. Then we introduce the concept. We look at crucial and important terms that must not be missed, because these terms are so vital to the discussion that we'll be having throughout February. So it's very important for individuals to become accustomed with those terms, because otherwise, if some of the terms are not very clear or are not refreshed, so the understanding of subsequent lectures or topics might prove a little bit difficult. Then we look at how to assess ability to maintain change in posture. Then we also look at postural control and stability. Then we look at balance confidence. And then we look at how we apply various tools and techniques to be able to assess such concepts or such aspects. So these are the areas we shall be looking at. So I just raised these points that as a clinician, do I worry that my stroke or Parkinson's disease patients are not recovering on time? Because this was one of the major concern of some individuals, that they say that neuro is difficult because patient doesn't recover on time, so it's frustrating. A lot of words and assertions, different people use different terms. So do we still have that worry? Just ponder over this. Then do I use correct or suitable terms related to balance and posture in my documentation and other clinical activities? Just ponder over it as an individual, as a clinician. These questions. Do I assess balance and posture in my patients with stroke and PD? When I say PD, I mean Parkinson's disease, sorry. Then do we objectively, or do I objectively track the progress or the recovery of my patients? Do I use tools or techniques that are appropriate or that are required by the patients? And how do I use those techniques? And are they always available to use? We ponder over this. At the end of the day, we will still make reference to this after this discussion and see if we do all this, or we do some, or we don't do at all. Am I audible, please? Hello?
Yes, you're audible.
Okay. So, these are my aims.
Can you make the slide in full slideshow?
Okay. Just 2 minutes. Slide share. Okay. Okay now? is fine, right? Okay. The aims now. The major aim of this discussion or lecture is to learn how to assess for postural control, stability, and balance confidence in stroke and Parkinson's disease. It means at the end of the day, we should be able to, for those of us who are already conversant with techniques of how to assess individual with stroke or Parkinson's disease, we should be able to refresh or to be reminded on how this is being done. And then for those of us who are new, we should be able to learn, okay, these are the methods or these are the ways we use to assess for either postural stability, balance confidence, and the likes. And it is also going to encourage us at the end of the day to apply these techniques or tools in our day-to-day practice in the clinics. So these are the major aims we intend to achieve at the end of the presentation. Okay, introduction. Before I start with the introduction, please, I just want to ask a question before continuing. We have a stroke patient that came to the clinic for management. So the stroke patient was sitting on a chair, and the clinician asked the stroke patient to stand off and walk very fast on a 15-meter walkway. The stroke patient stood up, started walking as fast as he could. Along the way, the stroke patient tripped and fall down. That clinician is trying to document or to narrate what causes or what happened that a stroke patient or a stroke survivor fall. In that situation, can we say that the stroke patient or the stroke survivor loses balance and fall down, or the stroke survivor loses stability and fall down, or is the same thing? Can someone just answer? Maybe two people. Yes, I know this.
Yeah, I would say the person has actually lost balance. The stroke patient lost balance while
Oh,
performing the activity.
okay,
Stability is just a subset of balance. So
okay,
that's my answer.
okay,
But meanwhile, what the physiotherapist did is an unsafe practice
okay.
because you shouldn't leave a patient who you've not assessed and you want the patient to fall down. It shouldn't happen at all. Yeah.
Thank you. Any contrary opinion? So it means we are all in agreement with him. Thank you. Let's now go in and see. We keep the question and the answer in mind. Okay, by way of introduction, this is just for us to understand or to refresh ourselves of the terms we'll be using during the presentation. We know that posture is referring to preserving or state of preserving a position by a body. That is to say, when a body is occupying a particular surface, that state in which the body is called a posture. So it could be a lying posture, it could be a sitting posture, it could be a standing posture. That's simply what posture means. While on the other hand, balance is a process or a procedure or an act or a means of achieving or recovering or sustaining a control while a body is in a particular posture or is in a particular task or is performing a particular action. So we could see how the balance is really different from a posture, meaning a body occupying a particular space, the state in which that body is a posture. But when any action of trying to achieve or to regain or preserve a control of that body while performing an action or while in a particular posture, we call that a balance. Then stability. Now, stability is the capacity or the ability of the body to return back to an original position or to a desired position or posture after it has been disturbed or disrupted. Usually the disruption is to the equilibrium. That is stability. So we could see how stability differs also from balance. But when we go to the next, we could now see how classically they differ from each other. So apart from the stability, balance, and posture, we now have postural stability and postural balance. So this is just English. We combine posture and then stability. So, but what differentiates them is postural stability, the capacity to preserve or to maintain body in a position to efficiently accomplish an action or a task using big muscles group. So can we see the difference? In postural stability, there has to be efficient accomplishment of an action using large muscle groups, maybe shoulder muscle group, trunk muscle group, lower limb muscle groups such as quads. So there has to be a efficient completion of an action before we could call a concept a postural stability. Okay, so now based on our initial question, can we now do we now agree with the answer given by Anoze, or we want to change our mind? Or I ask Anoze, do you want to change your mind, or you still want to maintain your answer?
I still want to maintain my answer.
Okay, based on this, right? Okay. Basic distinction between balance and stability now. In balance, the key terms that we must remember and we must not forget are four. Maintaining of a posture or a position. But here, I have an addition. It has to do with gravity alone. Gravity only. Gravity alone. It can either be in a dynamic or static form. I think this must be a mistake. It should be a dynamic or static form, and no acceleration is taking place. in balance. However, in stability, body has to return back to it from a disturbance. That is already a distorted form. So returning back to an interrupted position, then there is acceleration taking place, and then body responds to the acceleration to come back to the desirable position. That is the appropriate concept of stability. So Anozi, are you still with your answer or not?
Well, it's a bit confusing now.
Okay. What's the confusion?
I think I stay with my answer. Yeah.
Okay.
Yeah,
Do you?
because it has to do with gravity alone.
Okay.
And if the patient fell down, so he has actual action of gravity is there.
Okay. But
Patient fell.
yes. But remember the question. Do you remember still the scenario, the situation that happens? The
Patient
stroke survivor stood up. He started walking as fast as possible, moving along the line. He tripped and fell down.
Oh, then stability is also involved then.
That's where
With yes, because of the acceleration, definitely.
exactly.
Yeah.
That's the point there. So the most important thing I'm trying to point out here is that it's going to be a wrong use of terms or terminology to say that individual loses balance and fall. And a lot of the time we try to do that. The correct way is that that individual loses stability and fall because he's trying to accelerate and fall down, fell down. I think it's clear.
It's clear, but can I ask just a simple question?
Yes.
What if the patient just from sitting comes to standing and immediately comes to standing and falls down?
He
Would you
loses
say
his balance.
he
He
lost
loses
stability?
balance. He loses balance.
Hmm.
Because we have to look at acceleration when we are talking about this thing. Acceleration is the key. And when we are talking about acceleration, is change in velocity with speed and direction. Once there is no change in velocity with speed and direction, acceleration has not taken place. And if there is no acceleration taking place, then we are referring to balance. But in any
So when
situation
we talk
whereby,
about, sorry for cutting you,
yes,
I'm aware there is a static and dynamic balance. So where is the place of that?
no, it's not here. This is not part of it because when we come to static and dynamic balance, you see the classical difference because
Oh, okay.
they are two different things. Yeah, we shall come to that later. So it's like it's only I know they're talking. No problem.
I'm talking in the chat, sir.
Okay, I didn't see. Sorry. Stability is a product of balance. Okay. 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 So crucial terms in balance and posture, which we should try to refresh ourselves with. We have center of mass or center of gravity. We have center of pressure, base of support, line of gravity, equilibrium and limit of stability. We have standing balance, proactive balance, reactive balance, steady state balance, postural control, and postural adjustments. We should try to be conversant with this term because as we move, we should be discussing while calling some of this or most of these terms. So in order for us to not to face some difficulties in getting what we are trying to discuss, we need to brush over some of these terms. Okay, center of mass, center of gravity. We have been having it since our secondary school physics, so it's not a new thing. The only thing here is that we are trying to discuss it in relation to human body, not other objects. So it's a point or a location where gravity seems to be acting on the object, or a part of the body where the mass is distributed equally in all directions. So this center of gravity or center of mass, it usually changes with positioning of the body and also changes with the muscle mass of the body. Yes, sometimes individuals that are athletes, their center of mass used to change depending on the proportion of their muscle mass, either in the upper body or any other part of the body. This center of mass also has a direct link or has an association with the base of support in the body. Because the lower the center of mass, the more it is in the base of support of the body, and the more stable the body is said to be in, or the more the state of stability a body is said to be in. Therefore, the more the center of gravity is lower, the more it is within the confine of the base of support, and the more the state of stability an individual is. Then we have a center of pressure. This is a point where the ground reaction forces are seems or appears to be acting. That's where the ground reaction vector is applied on the surface. When we come to postural we will see how the ground reaction forces are acting. So center of pressure is not the same thing as center of mass. While center of mass is usually found around the pelvic area, second sacral vertebra per se in an anatomical position. The center of pressure is where the ground reaction force in the foot is acting. This is just a typical illustration of how we could see the center of mass around the pelvic area, and then we can see the center of pressure around the foot area. I think it's clear, right? Then the base of support is usually the outermost or the perimeter or the surrounding border. That's when you have the lower limb of an individual, the area surrounding the border, surrounding the foot, that is in contact with the ground, that is what is called the base of support. The higher or the wider the base of support, or the bigger the base of support, the better the stability. So decrease in this base of support result in increased acceleration and mobility. We will see this when we come to discuss issue of when somebody is trying to run or is trying to move slowly. The line of gravity, we could see it coming down. It's an imaginary line vertically, coming down vertically. It connects usually the COG, the center of gravity, down to the ground. Now, equilibrium and limit of stability. Equilibrium is usually a condition of acceleration. That is, it can be in a static form when an individual is not moving at all, or in a dynamic form when an individual is moving, but at a constant speed. Can we see? It's in a state of acceleration, but at a constant speed. That is why you could see that in balance, we could still refer to the aspect of equilibrium. But because there is what? Constant speed. However, when there is change in speed or a change in direction in the acceleration, then we are now trying to shift toward stability rather than balance. Limit of stability is the point at which the center of mass is approaching the boundaries of the base of support. So a point whereby center of mass or center of gravity is trying to approach the perimeters of the base of support is called limit of stability. On the other hand, you could say it is the greatest distance an individual can shift the center of mass through bending the body within the base of support without stepping or losing his balance. Is still called a limit of stability. So this illustration you can see shows, you can see we said center of mass nearing the boundaries of base of support. You could see the illustration coming down. Then you could see the arrows. Proactive and reactive balance. When we say proactive, is an English word. Once we say something is pro, we are trying to say it's before. So is the ability to contract or to activate balance controlling muscles, usually in the trunk and legs, before performing a voluntary movement. So once this happens, we call it a proactive balance. But in a situation whereby there is already trying or there is an ability to restore or to regain a position after unexpected balance loss, then we call that a reactive balance. Steady state balance and standing balance. Standing balance is simply a process of maintaining, achieving, or recovering the control of balance while standing. Similar to the typical definition of balance. While steady state balance involves control of the center of gravity in relation to the base of support under relatively predictable and continuous or constant situation. So in steady state balance, there has to be control of the center of gravity in relation to the base of support constantly under relatively predictable situation. Then we have the postural sway. Am I fast? I don't know. I think I'm so too fast.
Yeah, but
You are not fast.
continue.
You are not faster. Yeah.
Okay. Then we have what is called sway. Sway is nothing but movement of the center of gravity in a horizontal plane during standing. This is very important because when we come to discuss the issue of postural gravity, we will be discussing the concept of sway, sway area, sway velocity, sway path lines, all. So this is very important for us to understand what it means. So we are simply referring to the movement of the center of gravity in the body in a horizontal plane. The movement, it means it could be in an anterior-posterior plane, it could be in a mediolateral plane, dependent. Then sway area is the area swayed by center of pressure trajectory in relation to the central standing point. That's the area covered by the path or trajectory of the center of pressure when it's an individual is standing and then swayed. Then the path, the trajectory in which the center of pressure pass, the area covered is called the sway area. And that also can be measured in two ways. it could be in a direction of anterior-posterior plane or in a medial-lateral plane. Then we have the sway path length. This is a typical length or a common length of the center of gravity's trajectory path. That's the length this time around. You know, area you have to multiply, as in, is it physics? The length is just the length. But the area is usually comes in meters square, while the length comes in meters, right? Then we have sway velocity. This is also similar to the sway length. What just differentiates it with the sway length is you divide the distance of that length with the duration of the measurement. Then it makes it velocity. Are we together?
We are together, sir.
Okay. So in sway, we have directions. I've started explaining. We could have total sway direction, that's total sway area. We could have sway area in an anterior-posterior direction, that's on anterior-posterior plane. Then we could have sway area on mediolateral plane. Then we could have also sway velocity in the same manner. We could have sway path length the same manner. Each of the parameter could be in this form. Could be a total, could be in an AP format or form or ML form. Then there is also conditions in which the measurement of sway usually takes place. The condition could be that an individual could be asked to stand with eye open or with eye closed. That this is talking about visual input. That is whether there is going to be visual stimuli or visual perception or not. Then an individual also could be made to vary his or her positions of the limb. That is to say, the individual could be asked to stand with one leg with eye open, or with one leg with eye closed, or with two legs with eye open, or with two legs with eye closed. Then the surface in which the individual stands also varies. We could ask an individual to stay or to stand on a firm surface, that is on a ground floor, just a level floor. We could have a foam. Different type of thickness of foams could be provided for an individual to stand, and while varying the visual or sensory visual input and also the position or the proprioceptive sense, all in a bid to try to measure the extent or the level of either postural control or balance of that individual. Are we clear? I don't know whether I'm fast or I'm okay.
So
we
we're
together?
following. Maybe if you have any question, we'll just like maybe post it on the chat groups as you're
Okay.
continuing.
Sometimes when I heard that nobody talking, I'm used to discussion, not really for me to keep talking. Like
Okay, sir, no problem,
it's
sir.
as if it's boring.
I understand. I will definitely be, contributing. Thank you, sir.
It's so okay. So let's now start to enter the main aspects of the discussion. We will be starting with postural control. So the one thing that I want to say is that once we hear postural control or we hear postural adjustments, they are synonymous terms. And then three major aspects or systems in the body works together to control and maintain the postural control of human body. We know the sensory system, the central nervous system, and then the musculoskeletal system. They work in tandem with each other. They coordinate and provide neuromuscular mechanisms or processes that keeps postural control or postural adjustments. The sensory systems usually include the vestibular system that has to do with the ear, the visual system that has to do with the input from the vision in the eye, and then the proprioceptive sense from the positions of the body in space. So all these three comes together to work on the sensory system that helps us to maintain balance. That is why once we have deficits in either our visual part or vestibular system, for example, in vestibular system in elderly individual who are having either pathology, that's they having a disorder, or even elderly people that are at advanced age, that is those at uh, usually elderly, that's older adults. That's when you say people that are 65 years and above are usually individuals who are susceptible to fall or who are at risk of falling. So those individuals are naturally having some deficit they could have deficit in their vestibular system. As such, they will be what individuals they are called frail elderly. They are very susceptible to fall. They have high risk of falling, and then their balance is somehow distorted, despite the fact that they do not have any obvious pathology. That is maybe a disease like maybe a stroke, Parkinson's disease, or any disease that will be said to have caused a balance dysfunction. But being that they are individuals of advanced age, the deficit in the sensory, in the vestibular system could make them to have a problem with having appropriate or adequate balance. When we look at visual also, when you have an individual when you obstruct an individual vision, you are trying to suppress the sensory visual input, and you could see how it affects the balance of an individual, especially while standing. The same thing with proprioception. For example, when you say somebody should stand on one leg, it's going to be different from standing on two legs. So these systems works together to maintain our balance. That's in the sensory aspect. The central nervous system, I don't need to say much. We know the role and the importance of CNS in maintaining our balance system, where we have various areas that control and coordinate balance in our individuals. For example, areas that have to do with balance control when they are affected, for example, in Parkinson's disease and even in stroke, areas that control our balance once there is stroke or any problem with the neurotransmitters, then as in the case of Parkinson's disease, individuals are bound to have deficit or dysfunctions in the balance component of their body. Also, the musculoskeletal system is an important area also, because even if we have the sensory intact, the central nervous system intact, when we have problem at the down lower in terms of the musculature, either the joint has problem, the bones has problem, the muscle has problem, definitely the integrity of the balance of an individual is going to be affected negatively. So these systems, they must work together in tandem and coordinate for us to have appropriate postural control or adjustments in the body. So this is just a simple illustration showing the interplay between these systems. I think we've already discussed the central, the sensory, the biomechanics. I think what we didn't is cognition, you know, that's the psychological aspect of it, the cognitive aspect. Sometimes you could have all this aspect intact, but if there is problem with cognition, the balance of an individual is still dysfunctional. So this component comes together to give us adequate balance control in our body. Types of postural control. We have static postural control, This ensures that there is stability in the body by keeping the center of mass of the body within the base of support. So once the center of mass or center of gravity is maintained or is ensured to be within the base of support without going beyond the base of support, we term that as static postural control. But in a situation whereby, okay, it controls the unexpected center of mass movements outside or inside the BOS. Can we see? Once there is unexpected or unplanned movement of the center of mass outside or inside the BOS, static postural control regulates that. Hello? Okay. Then we have anticipatory postural control. This involves changes in posture prior to a movement. That is to say, the action has to be taken place before a movement, because from the word anticipatory is expected. So change in posture prior to movement is what is called anticipatory postural control. Then we have the adaptive postural control. This is a situation whereby there is going to be change in the response, motor response, due to a change in the task environment or environmental situations or conditions. So adaptive, it adapts, it gets used to. So functions of a posture. 1, it enables purposeful and voluntary body movement. So it makes us respond to unforeseen disturbances. That's disturbances that we are not expecting to happen. The posture allows us to respond to that, and it also keeps the body aligned in every position. So assessment of postural control and stability. Before entering the assessment, do we have any contribution, questions, or comments in the initial? Because the presentation is in two forms, in two sections. This, we are entering the second section now, the assessment, the main assessment. That is like an introduction of the general concepts. So do we have, let's discuss and have comments for like 5 to 10 minutes before entering the main assessment, so that we can get the assessment clear. You can write on the chat. If you don't want to talk, you can also speak if you want to speak. So let's discuss. Okay.
Yeah, thank you very much, sir, for the lecture so far. I just want to ask, I didn't get a clear difference between the center of mass and the center of gravity, um, as it relates with the base of support. So if
Okay.
you could just help me to, get a good understanding of that. Thank you,
Okay.
sir.
You know, we said center of gravity or center of mass. It has to do with the point in which the mass of the body is distributed equally in all directions. And when an individual is in an anatomical position, that part is usually found around the pelvis. Usually in some literatures or many literatures, they say it's in the second sacral vertebra. Is that clear for center of gravity?
Yeah, yeah.
So, but when you talk about base of support, you are now talking about the support, the lower aspect of the body now. Because if you look at the illustration we have, there is the area outside the edge of the sections of your body that is in contact with the ground. Once you talk about base of support, your mind should just go to the foot, your 2 foot in contact with the ground, the
Yes, sir.
demarcation.
Is there a difference between center of mass and center of gravity, sir?
Okay, I don't know. I didn't. I thought you want to know the difference between center of mass and center of base of support.
No, sir. I was
No,
just like the
when you
relationship. Yeah.
when you check, I'm even saying sometimes I will say center of mass, and sometimes I will say center of gravity. If you even
Is it the
check
same thing?
my my slide, you see that I put
Yeah, we lost you, sir.
From his slide, is clearly written now. It's still the same thing, center of gravity, or you call it center of mass. I think so.
Yeah, well, I'm just asking because I've seen it different in some places, and I was like, I want to be
Okay.
sure.
Yeah, the same
Yeah.
thing.
Okay. Thank you.
Yeah.
sorry, I've muted. I've been, sorry, I muted myself. Where did you lost me?
He has explained to me that he can use interchangeably. Yeah.
Yes, if you are talking about center of mass and gravity, it's usually used mostly it's being used interchangeably. The only thing is that it's just in the terms used. Sometimes it's used as some literature will tell you it's a point of mass distribution. That's when they say center of mass. You understand? Equally. But maybe when they say center of gravity, in some places they will say it's a point or location in which the weight is equal in all direction and is depend on the gravitational field. You understand? But basically,
Yes,
they
sir.
are synonymous.
Okay. Thank you, sir.
Any other thing?
So meaning that they are used are they used interchangeably, or
You
are we
can
talking of
you can use
the body mass itself, where the balance of both sides of the body is being concentrated on?
yes, sir.
Well,
I think the let me just say one thing that will clear the air. It's used interchangeably, but one term that is very important to differentiate this thing is that if you are talking about center of mass, the distribution of mass is equal in all directions. However, when you are referring to center of mass, it does not necessarily depend on gravitational field. But when you are talking about center of gravity, there is still equal distribution of weight in all directions, but it depends on gravitational field. I hope I did not add more confusion.
You can carry on, sir.
Yeah. So the concept of gravitational field can be used to differentiate the two. But the main thing in terms of the distribution of the weight is the same thing. It's just that in mass, there is no dependence on gravitational field, while in gravity, there is dependence on gravitational field. That's just the difference. Any other addition or comments?
and sir, how does hello, sir?
Yes, sir.
Somehow, when somebody is actually standing in an anatomical position,
Yes.
assuming, for example, someone that has a typical hemiplegic gait,
Okay.
and we see that the body seems to sway into probably a particular side, even when you are looking at the individual
Yeah.
directly, and you were now of the opinion that because we mentioned on sway the other time.
Yeah,
See,
yes, yes.
probably someone
Yeah.
now when you look at the base of support,
Yes.
I wouldn't know. It's only that I was a little bit off.
Okay.
I heard that you were measuring something like, for example, if you are trying to give example, I don't know how you were able to explain it. When
Okay.
somebody is running, in terms of
Okay.
running,
Yeah.
relative to this base of support,
Yeah.
and compare somebody that is standing,
Yes.
who is not actually not moving, then the base
Yeah.
of support.
Yeah.
And then when it's like you are trying to relate it with the center of gravity,
Yeah.
how how it actually stabilize someone trying to run is about the
Yeah.
base of support appears to have somehow reduced, that it
Yeah.
makes the person to run faster.
Yeah.
I don't know if I'm correct.
Yes. Yeah.
That it makes the person now run faster.
Yeah.
What does that individual trying to run after to make him running faster in respect to the center of gravity, or was the the center of base support in way?
Uh,
And how does that
you see,
together?
usually you see there is a difference in when you are talking about this concept of like mutual, especially the center of gravity and the base of support. Some characteristics of an individual really changes these things. For example, you talked about somebody who is a stroke survivor, and you talked about somebody who is running. For example, like an athlete, if I get
Yes,
you right. So
yes, sir,
now,
yes, sir.
for example, let me give an example. For an average human being, the center of gravity is around the pelvis center when they are standing in the anatomical position. That's whether a stroke survivor or whether an athlete. But this center of gravity, it shifts upwards slightly for males, for example, due to larger shoulder muscle mass. But in athlete, is usually athlete specific. That is, even among the athlete, it could be different. That is to say, an athlete with larger legs will have lower center of gravity. You understand? Unless or
Okay, sir.
otherwise, the upper body of that individual is also big. So it will now balances the mass. I don't know whether you understand. If an athlete has very large muscles in the lower extremities, he is bound to have lower center of gravity. In as much as the upper body muscles are not large to balance that center. Is that clear about that?
Okay, sir. Okay,
Yeah.
yes, sir.
So, but now when you talk about base of support now, there was a slide I was trying to explain the issue of when you have a larger base of support or a smaller base of support. I was trying to make a case of their association or their link with being mobile. So, for example, an individual who is running, if you want to run faster, by the time the base of support of an individual is increased, the ability to run faster decrease. That is like your mobility is being decreased because you are trying to like provide more stability to yourself. But once the base of support is decreased, sometimes it's necessarily when you come to the issue, we are not talking about gait. But if we are talking about gait, you could see it's linked to the issue of double limb support. At a time when you are running, the double limb support disappears. So it's like a similar concept you could apply maybe in the concept of base of support, that one individual is running The base of support, because if you have a wide base of support, it will not allow you to move with more mobility. You have to move slower. I don't know whether I'm trying to explain what you want to hear. Or
But that seems to will support a kind of stability in a way.
yes,
If the way, yes.
yes.
Okay, the
People,
person may not be able to run faster, but
yes,
have a base of support that's larger and maintain stability.
yes, yes.
I think that's the explanation, sir.
Yes, because there was even in when we are trying to gauge or to track the recovery of our patients. When patients come with instability or with lack of balance, sometimes we measure the base of support and see how it changes with time. And that even gives us a clue of whether that individual is improving or not. Because the lesser the base values of the base of support, the better then that individual is improving.
Okay.
Especially especially in people with stroke. We are talking about people with stroke here, with pathology.
Yes, sir. Yes.
Thank you.
Actually, because somehow when we are trying to treat a stroke patient
Yeah.
in ambulation,
Yes.
some of us actually apply this principle of this base of support that's making it narrower. Okay, the smaller the base of support now, it appears to have able to determine whether the patient will be able to maintain some precision in terms of
Yes.
walking.
Exactly.
Trying to maintain some precision. But at the initial stage, there's possibility that the patient will want to say, okay, let's increase the base of support. But as the movement goes on, it will
Yes. You now
reduce
reduce. Exactly.
yes, the base of support. Like when we are training the person on tandem walking, for example.
Exactly.
Uh-huh. So
Exactly.
we begin to reduce the base of support, and that in a way helping us to see that the patient is improving and once is able to maintain a particular pattern or parts in the probably in the foot what's it called now? The foot mats tandem walking pattern. So as the patient is able to reduce that base of support, then it's a function that his gait too will be equally be refined and then well positioned and be able to walk better than it used to be when the condition happens.
Yes. Thank you.
Thank you, sir.
You for information. Yeah. So let's enter assessment of postural control and stability.
Hello, sir. Hello, sir.
Okay.
Please, can I just come in?
Yes, sir. You can.
Just to go from the known to the unknown and to learn from practical examples all around us.
Okay.
We see that the lesser the base of support, the better the working posture for any person at any stage at all.
Yes.
For instance, when you look at small children, at the children when they are walking, learning how to walk, you see that their base of support is always wide.
Exactly.
They always walk without instability, trying to gather, and be support and balance, as they're walking, But as they get older and get matured, these are their base of support narrowed, and they're able to walk faster and better. So that gives us a practical understanding of what we are trying to teach us this morning. That as the base of support reduces, it helps your acceleration, helps your movement better. But when you're still trying to learn walking or learn how to move, your base of support might be larger to help you to create that sense of stability and to give that confidence to you. But as you improve in life, gradually that base of support will narrow down gradually. To give you better acceleration and movement, in space per time. Because the wider the space of your support, even there will be a sort of what you call the impact of dragging force. If you have to move, the wider your base of support, the more the dragging force upon your body when you are moving in space per time. Because it will be against larger surface area. But when your base of support is narrower, it helps to move faster, and able to beat even the dragging force as you are moving forward.
Yes.
So I think that's my own knowledge contribution to what you have been saying, sir.
Yes, that's the thing. But I think what brought a slight contribution there was a slide I talked about greater base of support, and I think the use of the word in that where the problem arises. Because when we talk about better, there is difference between better and then larger. So that's what. But this, what you explained, is perfectly what we are trying to explain to say in just a nutshell. So we are going to take assessment of postural control and stability in two forms. We have the assessment using the outcome measures, and then the assessment using the instruments. That's the objective tools. So in the outcome measures, we will be dwelling on posture for two scales under posture. That's postural assessment scale, and then the mini-vest evaluation system. Then we looked at balance confidence at the end. Then for the instrumented ones, we will be looking at posturography majorly, where we will appreciate the use of pulse or pressure platforms in trying to measure or to assess postural control in individuals. So we are now starting with postural scale. Hafiz, I think Hafiz, if you are there, can you please help us with the scale on the chat box and in the WhatsApp? People can go through it while we are discussing the copies of the
I have
scales.
shared it on the WhatsApp.
Okay, and so it's on the WhatsApp group. You can also attach it to the chat if you can, so that people can have a look at the scale. So the purpose of this, or the aim or goal of this scale, is usually designed for assessing postural control. That is the main purpose of this scale. And the main target population are stroke survivors. Usually this scale does not require any special requirement to conduct the assessment. The only thing required of an individual or a therapist, clinician that will be using this scale, is to be well acquainted with the concept of posture, balance, and fall. So all those terms we discussed, those concepts, an individual is expected or is presumed to be in the know-how of those aspects while using this scale, so that he can use this scale appropriately. So that's the requirement. When we talked about the scoring, the scale is a 12-item scale, that it has 12 items, and it is scored on a 4-point scale from 0 to 3. That is 0, 1, 2, 3. The scores that an individual could get overall after assessing all the 12 items using the 4-point scoring could either be 0, that means an individual scored 0 in each of the 12 items, or the maximum that an individual could get can be 36, because the highest score in the 4-point scale is 3. And the total number of the items in the scales are 12. So if we multiply the maximum score of 3 by the total number of scores of 12, we could have a maximum score of 36. There is no score better than 36 that an individual can score. So are we clear with this? So the items in the scale are divided basically into two. The first 5 items are for maintaining posture. All the tasks involved in those items are testing the ability of a stroke survivor to preserve or maintain a posture. While the next items from items 6 to 12 are items that test the ability to adjust posture or to change from a particular posture to another. So if you look at it from item 1, we have sitting without support, standing without support, standing with support, standing on the non-paretic extremity, and then standing on the paretic extremity. Now, if we look at it, mostly the zero score is a score that is trying to portray a poor score, because all the zero scores is trying to say individual cannot perform that activity. For example, a 0 score is saying somebody cannot sit, or somebody cannot stand even with support for item 2. For item 3, 0 means somebody cannot stand without support. For item 4, somebody cannot stand on the non-paretic limb. The same thing with item 5. So this scale is a positive scale in the sense that the higher the score, the better the performance of an individual or a stroke survival. Because, you know, we have two types of scale. There are scales which are negative, and then there are scales which are positive. For example, a time up and go scale test is a negative scale, in the sense that if an individual score higher, it means the performance is poor, because it requires shorter time for you to say, okay, you are doing well. So, but in a positive scale like this one, the higher score, the better the performance. Are we clear? Are we together?
Yes, sir.
Yes, sir.
Yes, sir.
Okay. Okay. So also in this scale, the next item, that is item 6 to 12, still when you look at 0 score, you can see that it means somebody cannot perform the task. For example, item 6 is trying to say, can individual move from spine to paretic side laterally? Cannot perform 0. Can perform without help, that is 3. That's independent performance. The same thing with item 7, cannot perform 0, can perform without help 3, that's the highest. Or with little help 2, or can perform with much help 1. So it depends on an individual, what an individual can do. So the clinician is expected to tick the appropriate score of an individual. Now, this scale can be used in stroke survivors, but is recommended at certain stage of recovery, and is also valid and reliable for certain stage, more valid and reliable for a certain stage of recovery in stroke continuum. So we will be looking at that in the next slide. What I wanted to say here is that the aim of supplying the scales in the WhatsApp and in the chat box is for us to look at the scale and then be able to use them in our clinics. This is like a homework or a classwork or something. Try to see, have you ever used this scale? If not, try to use it with your patient that has postural issues or balance issues, and then let's see. Because sometimes it's not about us coming here to talk. The practicality is the most important. Even if you understand here, sometimes to go to the field and apply it, you may notice some challenges, and then note down those challenges. And when we meet in the hands-on lecture, hands-on practical class that we will be having for the outcome measures, then we iron out those issues. Some of us that are experienced can give somebody who raised certain challenges on how to go about those challenges. We discuss, we brainstorm, and provide solutions to for effective patient management, and that should be the aim of the workshops we are doing. So the psychometric properties and other properties of the 6 scales are as follows. Is one of the most valid clinical evaluation for stroke survivors postural control in the first 3 months. Can you see what I'm saying? If a stroke survivor is in the first 3 months of stroke, this scale is more appropriate. We are not saying you could not use it for stroke survivors above that, but some studies or literatures have shown that it's more better to use it before within 3 months of stroke. It is a very reliable scale with excellent internal consistency, both for acute and subacute stroke. However, still I've seen some literature that says you could still use it in a chronic stroke. So that's why I think it's not a clear cut, but when something says maybe especially, maybe it tends to be better in that group. Responsiveness, you see the psychometric testing of responsiveness of the scale, it has shown that this scale better responds to moderate to severe stroke compared to mild stroke. So individuals who are, if you are having your patient having moderate to severe stroke, will benefit more from PASS than your patient who is having mild stroke. So you can see this is a question of a decision. As a clinician, as an expert, you need to have your expertise at your fingertips. For example, you have various scales of postures and balance, and you have your patient who is having a moderate, some of your patient having moderate stroke, some having severe, some having mild. So that is to tell you that it's not because you are using postural assessment scale for patient E, it must be used for patient B. No. The type of the condition the patient A, because number one is if a scale is not validated in a particular population, you cannot use it. So number one, depending on the condition that an individual is presenting with to you. So even if you have a patient that is presenting to you with a balance problem, but the scale that you are using is not validated for that patient, you cannot use it to measure balance for that patient because there is no evidence. However, even within the patients that are validated, like for example, the postural assessment scale, which is validated for stroke, you could see that even among the stroke patient, it's more responsive to a particular form of stroke than another. So that is for you as an expert to make such decision, and that distinguishes you from any other person who is not an expert in the field. So this is our postural assessment scale. Can we move to the next, or am I too fast?
No, sir.
Okay.
Yeah.
I think you have
Yeah,
the scales with you, right? Okay.
Yes, sir.
Okay. Somebody is talking.
It's clear.
Yes, sir.
Yes, sir. It's just that we so that's okay. Probably during time of question and answer,
Okay.
and
Okay.
responses.
Okay. So the next scale we shall be looking at is mini vest. It's called balance evaluation system originally. So, but later it was remodified to have the mini type, which was also being validated and reliable for use. And so the purpose is it was designed for assessing stability and postural control as well. And the target population usually are stroke survivors, individual with Parkinson's disease. We could have others, but because this presentation is centering on Parkinson's disease and stroke, I try to limit myself to these two conditions or something that is related to them. For example, senility or older age is usually associated with especially Parkinson's disease. So you could see me saying older adult in some places just because I know older adults, mostly Parkinson's disease come up in individuals who are older adults. Now, requirements. Here we have requirements. Apart from a clinician being supposed to be conversant with the concept of posture, balance, and balls, there is supposed to be what is called T-foam, 4-inch thick. There is like a foam which is a 4-inch thick with medium density, and we're supposed to have a chair with no armrest or a ramp that is inclined. There has to be a 3-meter distance and a stopwatch. These are needed. Once you want to do mini vests, you should have these requirements ready in your clinic before beginning mini vest assessment. Now, scoring. It is a 14-item scale, and each item is scored on a 3-point instead of 4 in the other one. Here we have 3-point scale, and it's from 0 to 2. 0, 1, 2. 0, 1, 2. Then the average score or the range of score total that an individual could get is either 0, which means worst performance, or 28, which means best performance. That is to say, this scale is as well what is also a positive scale, because the higher the score, the better the performance in an individual. However, there are some caveats to this scale. Although 0 indicates lower level of performance or function, 2 indicating highest level of performance or function, if, for example, during the use of the scale, an individual use assistive device for an item, so there has to be something, the score on that item has to be taken into consideration. Then if an individual requires, for example, much assistance, maybe physical assistance from an individual to perform an item, even if that item or that task is being performed, 0 is going to be used for that item, because there is what? Physical support. You know, there is difference between physical support and use of assistive device. For example, somebody said he could perform the task, but he need a walker or a walking stick to perform that task. So even if he performed the task that could warrant him to get 2, he would have to be given 1. But if the person say he cannot even use walker or walking aid or walking stick, but he needs somebody to hold him before he can, or support him before he can do, definitely 0 should be scored for that task. Is that, are we clear?
Yeah.
Okay.
Yes, it's clear.
Okay. Then also there are other caveats. For example, for item 3 of this scale, that has to do with standing on one leg, and then item 6 that has to do with stepping compensation. The score for one side should be included, please, not for the 2 sides. Is that clear? Are we there?
Yes, sir.
Yes. Then there is also an item that has to do with time up and go task. Time up and go will be discussed later, so I will not need to what I just want to say here is time up and go with dual task. What do we mean here by dual task is just what I want to explain. Dual task means somebody is performing 2 concurrent tasks at the same time. And the dual task can be dual motor task, or dual cognitive task, or dual cognitive motor task? Are we together?
Yeah, we are with you, sir.
So when we say dual task, dual motor task, for example, somebody is being asked to walk, to stand up from a chair and walk to 3 meters and come back, maybe in time up and go. So while that person is doing that, he is being given a glass of water to hold in his hand to perform that task. That is called dual motor task, because he's doing two tasks. He's walking 3 meters and he's holding a glass of water at the same time. That is dual motor task. Then there's dual cognitive task. Dual cognitive task is like, for example, you give an individual a screen of computer, and you have maybe you have some colors coming out, maybe blue color, green color. So you ask that individual to respond to those colors as they come out. And while he is responding to those colors as they come out, he is also calculating. For example, you are telling him, okay, subtract 7 from 50 backward. And then you also respond to, you tell me whether this color that come out is yellow or blue. So he's responding to color and at the same time doing subtraction of 7 backward. That is dual cognitive task. Then there is dual cognitive motor task. Dual cognitive motor task is in the sense that individual is being asked to stand up, walk 3 meters, come back. As he does that, you ask him to keep maybe counting maybe 7. After maybe you say, okay, count 9. From 9, you jump 5 and say another number. Keep jumping 5 and tell me which number is the next while he is also walking. That is, or you say, okay, keep subtracting 9 from 100 backward while you are walking to go and come back. That is dual cognitive tasking. So that's what I just want to explain, because that is the only area I think that it's maybe a bit confusing in the in the scale. Yes. So you can see the
All right,
item.
thank you, sir.
You can see the item. We have the sit to stand, which is clear. We know what is sit to stand. Rise on toes, that individual to rise on his or her toes, standing on one leg. I believe it shouldn't be a difficult thing. Then compensatory stepping correction forward. Then compensatory stepping correction backward. Then the laterally. Then stands feet together, eyes open on firm surface. Firm. What is firm surface, please?
On a hard ground, normal
Okay.
ground.
Okay. Then there is one on firm surface. That's like on a form. Then there is one on incline. That's like an incline ramp that we say you're supposed to have when you want to do this the testing. Then you walk. Then there is change in speed. Then working with turning the head horizontally, and then working with fiber turning. Then the other one that I just explained, which I believe should be the one that is a bit confusing. That's time up and go with dual tasking. Stepping over an obstacle is also, I believe, should not be an issue. So the same thing as we did with the scale, that's the PASS, the postural assessment scale. Please, we should also have this at our fingertips, and then try to go and study it very well, and then see if we can have it applied on our patient. That is why we left the hands-on to be toward the end of the weeks. That's, we have like 4 weeks, 4 Saturdays. Maybe we'll have one Wednesday. So, but it's going to be toward the end, so that by then people must have practicalized these things on their patients in their clinics. Then that is when we know, yes, the aim of the hands-on is being achieved. So when people go and use this scale and come back with feedbacks, that makes it interesting and better. So please, let's try and see we use it in our patients. Even if we don't have patients to use, we could find a subject in the clinic. For example, you didn't have a patient that warrant the use of this scale and the time is approaching for the hands-on sessions. You could use a colleague, and a colleague could use as a subject. You try and use practicalize and see how is it practically. Very vital. So let's see the properties of this scale. It is a valid scale in stroke, especially mild to moderate chronic stroke and in Parkinson's disease. Can you see? It's in chronic stroke, but the chronic one has to be a mild or moderate one. And in Parkinson's disease, it was found to be excellently reliable in stroke and also in Parkinson's. The scale demonstrated responsiveness, but moderately, in trying to detect dynamic balance improvement associated with treatment in Parkinson's disease. And you see, it was also found to be the strongest predictor of fall in those with Parkinson's disease. So you could classically see that, okay, if you look at it very well, the initial one we use, postural assessment scale, is more of for what? Acute and subacute stroke. But here is saying what? For what? For chronic stroke. That is in terms of stroke. But the initial one, I'm not sure if I have seen a literature that it has been validated in Parkinson's disease. That's the past. But you can see this mini best. It has been what? Validated for Parkinson's disease. So that is to tell you, if you are having different patients, they will have different outcome measures. It doesn't mean that because you have mini best for balance, you apply it to all your patients. No. Or you have postural assessment, you apply it to all your patients. No. A lot of factors have to be taken into consideration before you apply this particular scale. For example, even in Parkinson's disease, if you have two scales for postural control, but one of your aim is you want to predict fall in those people with Parkinson's disease, the best scale for choice should be mini best, because it's the scale that has been found to be a strongest or the best predictor of fall in those with Parkinson's disease. Therefore, the choice of the scale also it matters, because if you use the wrong scale, you might not get the correct result, and at the end of the day, you could be seen to be not be doing well, while in essence you are doing well. When we come to the postrography, is where I will explain those things in detail, especially the aspect that the first item I put in point to ponder, where I said, do you worry that you are not, or your neuro patient are not being recovered on time? Why the use of that is that a lot of factors makes us to worry while we are not supposed to worry. Number one is that what I'm explaining now. If you cannot use an appropriate scale for an appropriate condition at an appropriate situation, you will not get the appropriate data. When you don't have the appropriate data, it means you cannot track the progress of the patient you are managing. And if you are not tracking the progress of the patient you are managing, you will be affected psychologically because you feel you are not doing well. The patient will also be affected because the patient will feel you are not giving him the best, while in actual sense, all are not correct. But because something was wrong or is wrong along the way, that is why those two things happen. And that will continue to happen if you didn't, or if you are not properly using what you are supposed to use in your assessment or management of the patient. So when we come to posterography, you will see, because in posterography, you will see how minute, very small progress or very small information can be picked up. And you could use that as an evidence of an improvement in what you are doing. Are we together? Am I audible?
Yes, sir.
Yes.
You are.
So let's go to the next scale that has to do with balance assessment. So this scale comes up because of follow-up explanation of what I just explained. Sometimes you will treat your patient very well. You manage the balance issue. You've done excellently well. You are very confident that that patient has recovered. But the patient, you ask the patient to perform a task, the patient will tell you cannot be able to perform. And you check all the motor components, all the physical components, they are intact and perfect. You now begin to wonder what is happening. That is why you have to take into consideration all aspects in the patient. So that is why when we are trying to assess balance, we cannot only concentrate on assessing the physical aspect of balance, but we must also assess the psychological aspect of balance. Because if you did not assess that, you could succeed in managing the physical aspect. But if there is problem with the psychological aspect, the result of your physical aspect will not be shown. And as such, it will still go back to what I just explained, that you may be thinking, or the patient may be thinking, you did not do well. But in actual sense, you did well. So let's enter activity-specific balance confidence scale and see what it does. This is a scale that is designed to evaluate balance confidence subjectively. Why is subjectively? Because it's a patient-reported outcome measure. The patients can tick and score as against the other ones. You can see there are a little bit, there are some element of a clinician administered. You are the one to ask them to perform a task and then you score. But this one is like a questionnaire. It's more or less a questionnaire that you give the patient to score him or herself. And it's been validated or targeted for patients with stroke, those with Parkinson's disease, movement disorders, older adults with various balance dysfunctions, all could, this scale could be used in those populations. Now, the requirements. The main requirement is that users should be competent with the concept of balance, posture, and fall as previously. Apart from this, there is no special requirement that is required of an individual to perform this task or this to use this scale. So the scoring is a system item self-report scale. And the items are scored from 0 to 100% with an interval of 10%. That is, the individual can choose either 0, 10, 20. The interval is 10, 10 between one score and another, with 0 meaning zero confidence, or with the individual has no confidence at all in performing a particular task, or completely confident, that is 100%. So each of the 16 items is being scored using this scores. So the individual is being asked to rate his confidence or her confidence in carrying out the 16 item task. And at the end of the day, the total score is obtained by the summing the individual scores for each of the 16 items and then divided by the total number of the items. You understand? And then the score you could get or an individual could get is if the lowest score is 0, while the highest score is what? Is 100%. So if you look at this scale, it's also what? This scale is also a positive scale with higher scores indicating what? Better confidence in carrying out tasks, or lower score indicating least confidence in carrying out tasks. So this has to do with balanced confidence, or you could say balanced self-efficacy. That's the ability of an individual to say whether he or she can confidently carry out a particular task. So these are the items walking around the house. So you should ask the person, or the stroke survivors should be asked, how confident is he or she in trying to walk around the house? How confident is he or she can walk up or down stairs, can bend to pick something from a floor? I think I've repeated that twice. It's supposed to be a single item. It's a mistake. Then how confident an individual will reach for a small can off a shelf at an eye level, at the level of the eye, then stand on the tip so and reach something above the head. Stand on the chair and reach for something. How confident an individual or a stroke survivor can sweep a floor, or an individual with Parkinson's disease. How can that person walk outside the house to a car park in a driving area? How confident an individual can get in and out of a car, can walk outside, can walk across the parking lot to the mall. You remember, walk up and down the ramp. You know, ramps in the clinic where the wheelchair passes through. Walking in a crowded place where there are many people and a lot of people are walking past you, either across, against, or near you. Step on or up an escalator while holding the rail. So on the escalator, there has to be holding the rail. Note that there is no holding a rail. There's also the last one is the 15th one is holding on the escalator without holding the rail, because when you are not holding the rail, you are more independent. Walk on icy sidewalks. Then I think it's okay. There is this one, bumped into people. But I think I didn't say as you walk through maybe a mall or a big market gathering. So psychometric properties of this scale. It is a valid scale in stroke, Parkinson's disease, and older adults. Usually those above the age of 65 years. It was found to be excellently reliable in stroke, Parkinson's disease, and older adults. It has the higher item responsiveness. So because of this higher item responsiveness, it makes it a suitable scale in detecting balance loss or loss of balance confidence. So it also aids or helps in objectively assessing patients' subjective perception or view of their current level of balance. Can you see? It's objective. We are not saying it's an objective scale, but it objectively assess the subjective perception of the patient. So this is about this scale. So this one is has like a more of a questionnaire that you could also administer to your patient and see, put it side by side. So sometimes, even if you have your treatment done and you're trying to track the recovery of your patient, you could have, for example, some of our scales have ceiling effects. I think if I remember, the back balance scale, yes. What we mean by ceiling effect is that you could have somebody maybe having the highest score. You could have your patient, you scored it with your scale, and the patient scored almost everything. But you still observe some deficit in the patient. So what I'm just trying to say here is that if you have scale, like for example, the two scales we just discussed on balance, and for example, your patient came and you assess the person with the scales and you found out that the person has done excellently well, scoring almost everything. So this ABC could help you in identifying some silent issues that may not be raised there as maybe limitations of your scale. Because, for example, you could see somebody scoring higher score in a particular item in the physical scale. But when you come to this, the cognitive or the self-efficacy scale, the person will write a lower percentage in carrying out a particular task. So you begin to wonder what happened, that the person has scored high score in that similar item in a physical score, but is writing a lower percentage of confidence in carrying out that task. So that is for you as an expert to now look at, okay, what are the reasons? Discuss with the patient, okay, this is the score here, but this is your score here. So you now begin to see, okay, what are the reasons? Could it be that there are some things left that you didn't do, that you need to do more, or you need to refer the individual to an appropriate specialist, maybe for counseling or something? That may end up improving the whole component of the care for that patient. And that is the advantage or importance of using some of these outcomes, trying to assess or track the recovery of our patients. So that is that about these skills. The next section I will be entering is the objective instruments. So I don't know whether we will take comments now or we leave it after the photography. Which one do you prefer?
Hello, sir.
Yeah.
Yeah, I'm thinking we could just have a break, then come back.
Yeah. That's short break, right?
Yeah, depending on you, could be a short break, could be a long one. I don't know.
Because we will have maybe, depending, Dr. Bopper will start after I finish. So maybe between his own and my own, we could have a break.
Okay. That makes sense.
Yes. So, but if you still want break, we can have like 5 minutes to.
Yeah, can we just have like a 5 minutes break? I don't know if other
Stretch.
people, yeah.
Yes. If you have your comment, you can reserve them after 5 minutes. We continue.
I just found time. That's what we're doing, and what's I do?
sọ pé ẹ ti wà ń bẹ ẹnì kan para patient bá ti yá tó bá dé ti di pé òfin di kó ń bẹ patient pé kó wá gbàtọ́jú tí ó bá sanwó kì í ṣẹ̀bi rẹ̀. ọ̀gá ẹ̀ ṣe yẹ dáadáa o ọmọ wa àwọn wa pọ̀ sí ẹ̀ tí ì sanwó.
Okay, I think we can resume. Already 5 minutes.
Yes, sir.
Thank you. So we have 10 minutes. We can continue, I think. So do we have comments or questions before we move to the next?
No, sir, you can continue, sir.
Okay.
Hello, sir. I have a question, sir. Hello.
Okay.
Hello, sir. Can you hear me?
I can hear you.
Yeah. Oh, thank you, sir, for the wonderful presentations. I just have is a form of clarifications and let me say a question anyway. So, in regards to the ABC skill, I don't know if you are aware of a CONVAL. CONVAL scale is to assess confidence in elderly for patients. So my question is this one more reliable or valid than CONVAL?
Con what? Con what?
CONVAL, confidence balance, CONVAL.
Yes.
Can you spell it?
2009.
CON help, then balance.
Okay. For LD.
Yes, CONVAL.
Okay. So you
Yeah,
want
my second question is in regards to mini best skill to assess balance. So my question now is there any limitations at which this particular scale can be used? Because the kind of category of patient that I'm seeing, I'm into elderly for PD patients in the community. So I guess that you said this is very best, the most recent one. So my question is there any age related at which this particular square measure can be used? Maybe 65 because I work majorly around patients that are 65 years and above. So is there any limitations towards this square measure?
Okay, thank you. The first one you talked about the CONVAL. I've not checked whether it's between it and ABC. It's which one is more reliable. So you could help us as part of your research now. Later we can discuss it. You check for us based on literature, whether the literature has tried to compare the ABC and the CONVAL and see. And then it has to be in maybe elderly individual or in stroke. It has to be in similar population. That's one. Then two, regarding minibest, yes, minibest, I say it has been validated for use in stroke and older adults. So once we say older adult, we are referring to individual of 65 years and above. So once we say individual, older adult, we refer to, so it can be used perfectly for those group of patients or individuals we are dealing with. So there is no limitation.
So the reason why I asked this, if you look at the last phase of the outcome mayor, it talks more about how we analyze the gates, work normally, then work the moderate working and the likes. So most of the patients I'm working with, they use working aid. You know what I mean?
Yes.
They use something to work with. So how are we not going to put that one into place?
Yes.
You know what I mean? Yeah.
Yes. I think I've discussed this at the beginning. Maybe you join or something. You remember I said if an individual must use an assistive device for any item, you score that item 1.
Okay. If
the individual has to use a physical assistant for any item, you score that item 0. I think it's clear.
Yeah, sorry, I joined late. I think I didn't get that one. Yeah.
Okay.
Thank you.
Yes. So
thank you, sir.
Okay. Can we move to the next? Posturography or posturography. This is an objective procedure of assessing postural control through instrumented testing using pressure and force platform. The reason why I brought up this method is that I know we might not have this readily available. I'm not sure if we have any center in Nigeria that has this. I'm not sure. unless if someone has it in their center, they can speak here. Either they have the pressure or post platform for postural assessment. Then we know. I'm not sure if they are not even maybe are very much. They are not many. If they are at all, they are. But why I brought it up is that these are some of the objective measures we need to use, because all the other skills, all the paper skills, they have their own limitations. Although these ones also there is no perfect skills, they have their own limitation, but at least we tend to see that they may likely be more objective in giving you some of the values. Okay, so low volumes. You can't hear me? What up now? Am I okay now?
You're okay, sir. We can hear you.
So is they tend to give more better objective values and reliable values that we could use in any, maybe in tracking the progress of your patient in any aspect of your patient management. So that's why I brought it, even though we may not have it available, but one day we will also we may have it available. Another way is that you could have it as maybe as a stimulant to encourage your centers to recommend and suggest to your management and centers to make provisions for such type of advanced instruments used for this kind of testings or assessments. Another way is that the participants we do have in this workshop are not only participants in Nigeria. I see a number of people that are outside Nigeria, which I believe in some of those areas, the countries we could have this type of instruments that is used for the assessment. So that is why it's still a good idea bringing it up to discuss it, even if it's not readily available in Nigeria. That is just by the way. So it's an objective procedure. Is somebody talking? Of quantifying the postural control using force platforms or force plates and pressure platforms or pressure plates. Usually, center of pressure is the most commonly used outcome measure in this procedure. It can be used, the procedure or the process can be used to characterize and measure postural stability, and it could be performed under dynamic or static situations. Now, the postography situations now. We have the first situation, which is called several surface situation. I think I've explained this before, but I will just do it again. What this means is that this postography where we use force platform or force plates, we could have several surfaces that individual could be asked to stand while we want to measure some postural or balance parameters. Example is that a firm surface on the level ground, maybe on a form that is of particular thickness, on a rough surface, depending on the surface, just to challenge the balance of an individual. So various different types of surfaces could be used when testing balance or postural outcomes using posturography. You could have just various or different types of stance position. For example, individual could be standing on one leg, could be standing, that's the one leg could be if an individual is struck survival, we could say, okay, stand on the paretic, if the individual can do that. Stand on the non-paretic, stand on the 2 feet close together or 2 feet wide apart, depending on the stance we are interested in. If an individual is not a stroke survivor, for example, an apparently healthy older adult, we could say, okay, stand on the right leg or limb, stand on the left limb, stand with the two limbs close together or apart, depending. So different stance positions could be used to assess different postural outcomes using posturography. Absence of visual perception, visual input, visual stimuli. We could have a situation whereby the individual being tested or being examined will be asked to perform a task or to stand in the absence with eye closed. That is in the absence of visual input or visual, and then find out the major postural outcomes in that situation or in that condition. You could also have a situation or condition whereby an individual could be asked to perform a task or to stand in a particular position or posture with the presence of conflicting or distracting visual input or stimuli, and see how the measurement of postural outcomes could be using posturography. So these are some of the various situations or conditions you could adopt to use when measuring postural outcomes in posturography. These situations could be used independently or could be used in combination. Example, when we say we want to use them in combination, for example, you could say we want an individual to stand on a firm surface with eyes closed on one leg. In this situation, we have combined three. That we combine surface, stance position, and absence of visual input. Or we could say the individual should stand on a foam mat with eyes open and then with in tandem standing. That's with legs maybe close together. In this situation, we have combined surface, presence of visual input, and then a particular stance position. So we could vary it different ways. So these are how these situations or conditions are used in measuring postural outcomes in posturography. Types of clinical posturography. We have the static and then the dynamic. In static posturography, here is the ability to maintain balance on a fixed platform or plates in different situations. That is individual, some of the outcomes you could measure here could be you want to measure sway, want to measure limit of stability, want to measure weight shift, want to measure asymmetries. This can all be measured in situation of preserving or maintaining balance on a fixed platform in different situations. The situation is those ones that I already mentioned. So we could have a fixed platform and then individual maybe is being asked to stand, and then we now vary the situation with, okay, stand on paretic leg, eye closed, on a maybe firm surface, and then see how we measure the sway, how we measure the limit of stability, how we measure the weight shift or asymmetry, depending on the outcome of interest. That is in assessing static in the process or in the method or in a type of static clinical posturography. We also have a dynamic clinical posturography where we assess or quantify the postural response, postural reactions to changes in visual environment, the support surface rotation or translation. This is to say that this is not only assessing a fixed situation, but rather a change in posture or reaction in posture to changes in visual circumstances, or the surface that is supporting the body that is being standing there, the rotation of the surface or the translatory movement of that surface, the changes in those things, there is going to be a postural reactions or response to those changes. So we want to see, in this situation, it has turned to dynamic because there are already changes and adjustments, not longer a fixed position. Because if you look at it, in the study, we are saying that we want to change, we want to measure postural outcomes from maintaining ability to to balance on a fixed platform. The platform is not changing, but in dynamic posturography, there is changes in the support surface, either rotation, either translational movement, or in the visual circumstances. So the postural response or reaction to those changes, that is what we are measuring, those various postural outcomes related to that in dynamic clinical posturography. The method of clinical posturography. We have basically two methods of clinical posturography. The first one is called the computerized dynamic posturography. This involves the use of platforms such as the NeuroCom Smart Equis test platform to evaluate parameters such as center of gravity, displacement, and limit of stability. There is a second one which is called mobile posturography, whereby a vertical system is used to carry out a standard test. The problem with this is because we don't have them, and I should have provided a picture. It skipped my mind on how we could appreciate how these things are. But let me see before the end of the discussion if I can have some pictures that will help us in appreciating more that how these things are done, so that it will not be like we are speaking in the abstract. So usually in the computerized dynamic posturography, there is mostly related to sensory organization tests, in which the displacement of the center of mass is being tested in various sensorial positions, such as maybe you have a fixed surface with visual surrounding and eyes open. You have a fixed surface with eyes closed. You have a moving surface with eyes open and fixed visual surrounding. You have a moving surface and eye closed. You keep changing, the surface and the surrounding. So because if you look at it, we say computerized dynamic. And remember we said in dynamic, there has to be either changes in the visual surrounding or environment or the platform movement. So that is why all what I'm trying to say, you could be hearing me saying visual something or platform or surface something, because those things has to change once dynamic is already included in what I'm saying, because I said dynamic posturography. Also, under dynamic posturography, you could have, under computerized posturography, you could have what we call measurement or assessment of limit of stability. Here, you follow the visual feedback. The patient has to move voluntarily his center of gravity without moving his feet or her feet on the platform, to reach a particular point around him or her. So you could see this point represent the displacement in the limit of the subject's center of gravity. So you could see indirectly what we are saying is that, for example, in the limit of stability is more of we are trying to more associated or more linked with static posturography, where there is no movement in the surface, while in the aspect of computerized posturography, where we measure all those different positions in terms of changing in the vision, changing in the surface movement, is more linked to computerized dynamic posturography. But that has to do with movement in the surfaces or changes in the visual environment. So this little about the beauty about this thing is that you don't need to do much. What you only need to do is to provide the enabling environment for the participant or for the patient, get the instrument ready in a perfect condition, and then your only work as a clinician is variation in those situations that I explained. Either variation in the stance position, that's instruct the patient to vary those things. Because it's self-computerized, all the information will be captured and be measured by the computerized by the platforms. Automatically, you have your readings. This brings me to the place that I said I've started explaining that you could have been doing very well treating your patient, but if there are no some enabling environment to allow you track progress, discuss progress, see what you are doing, no matter how it is, then you could be seen not to have been doing much. For example, here we are talking about force platforms, force plates, pressure platforms. These are instruments that have the ability to detect the sways, for example, the sway area, the sway velocity, the sway path length. They can detect it in every direction, either in anterior, posterior, medial, lateral, and it gives you reading. In essence, what this is saying is that if you have your patients firstly coming to your clinic, if you have some of these instruments ready and available, you already have your baseline. You measure, you assess your patient, you know at which level the patient is. You begin your management. At interval or periodic interval, you keep checking and testing the patient to see whether you are progressing in the treatment or not. In such instances, even the patient is an evidence-based thing. The patient will see for himself whether you are working or not. So in essence, what he's saying is that some of the notions that we could have as maybe neuro conditions not being getting recovery on time, it may be that we don't have some of the things that can detect the early recovery, no matter how small it is, because it's something of appreciation, even if there is small recovery, than to say there is no recovery. But if you don't have something to quantify that recovery objectively to show that there is recovery, you cannot manufacture one, or you cannot manufacture and say there is recovery. So this thing can catch as small as little values that will show you whether there is retrogression or whether there is progression in your management strategy, which will be of immense value to your treatment and to your patient rehabilitation in general. These are my take-home message, that as a clinician, I need to improve on or need to use appropriate terms relating to balance and posture, review my posture and balance assessment strategies in stroke and Parkinson's disease, and even in older adults, by extension, improve my documentation in case folders using suitable terms, not to interchange center of gravity with center of mass, limit of stability with line of gravity, balance with stability, posture with balance. I have to be as professional, because as a movement expert, you must have all this at your fingertips, so that when you are talking and discussing, you know, or if you speak, people know that you are an expert in your field. Periodically track the progress of my treatment using appropriate postural control or balance assessment technique. Even if there is no posturography, that's force plate or pressure platforms available, the other paper skills can still be used to track the progress of the patient. Discuss my treatment progress with my patient using the result of my assessment. One of the things that we sometimes forget to do is that we major, even if we major, we document in the folder without discussing with our patient. That will also be a negative, a disadvantage on our side, because we need to be open and be discussing with our patient. That was what will give the patient confidence of what we are doing, and the outcome of the care will be improved. So in conclusion, I close with saying posture and balance assessment are germane in the rehabilitation of patients with stroke, Parkinson's disease, and I have my references. Okay, this version. Then I want to make an correction here. Please, there is an information that I want to give, or a correction here. It's a mistake, so that people can take notes. It should be misleading. There is a place under balance where I discussed types of postural control. Sorry, I think under postural control. Yes, here. This is reactive postural control, please. You can see two static. This is reactive. There are four: static, reactive, anticipatory, and adaptive. This second static is reactive postural control. So thank you all for listening. So let's open for discussion now, so that we can close for the second session. Thank you. I already have some question in the chat box, so maybe I should start with them. Hello. Let me start with some questions in the chat box, please. Someone asked that we have items on the ABC scale that, for example, icing work. So what happened in our situation in the places where they don't have that? How do patients respond to that? Hello? Hello?
But with you, sir.
Yes,
we can hear you, sir.
Okay. So
We can hear you, sir.
what we have is not only the icing. There are two items in the ABC, three also, I think. There is the one that I talked about, escalator, right? There is number 15, number 14, 15, 16, the last three. I think those ones, especially in the Nigerian context, we could have some difficulty for some patient to because like for escalator, if not maybe places like airports and some few other places, I don't think people have that much access to escalators. So one of the things we do is, this is called or brings the issue of cross-cultural adaptation, where you could cross-culturally adapt a particular scale, that is to adopt it in your setting, that is to do the scale again, reconstruct the questions to suit maybe your environment, or translate it to your language and do a better translation that will better reflect those aspects. But that scale has to also be checked for psychometric properties. And even in some scales, you need to even seek permission from the original developers of the scale, while in some, there may not be need for that. But in, for example, a situation whereby in some scale that has been done already, so you could search. I'm not sure whether ABC we have it already translated. So if there is, fine. I think it has been done. I think there is. I don't know which version. I think there are some versions translated, but sure there are translated versions, even in Nigerian language. So if there are, you could use that. If they are not, in the interim, maybe if you are using it, you could try to use it to maybe put it in a way that the patient could understand what it means, because of initio the scale is a subjective. There are subjective questions. It's somebody that is telling his or her confidence of doing something. So how do we measure? Somebody asks, how do we measure the recovery that is mild, moderate, or severe stroke? Yes, here also it's still boil down to the use of scales. There are many scales you could use to measure stroke severity, many of them. Maybe which there is NHSS, this National Institute of Health Stroke Scale, right? There is Los Angeles Stroke Screening. There are many scales you could use to assess the severity or disability level of stroke. So you use an outcome measure based on the score of the individual patients, and then the cut-off score, the outcome measure will tell you from particular score to score is mild. So score is moderate. From so score is severe. So where the patient falls, you can be able to appropriately classify the patient with that class. And then you could now see whether you could use a particular outcome measure for that class or not. Thank you. So any other comments? Addition? Subtraction? Hello? Comments? Okay, somebody has unmuted. Akinjole.
Oh, no, sir. Sorry, sir. I don't have any question.
Okay.
Sorry.
Any comments? Addition? There should be. Does it mean all everything clear? I'm not sure. Adisa.
Thank you very much for the lecture, very enlightening. I would like to, looking at the pictures now that have been sent to the chat box, I'm trying to really, I don't know if you can just speak to the pictures, just to sort of elaborate on the posturography, if I got that right.
Okay.
I don't know if you can just speak to the two pictures so that we get like a context of what you explained earlier. Thank you, sir.
In posturography, what we are trying to say is that we use a post platform. We use an instrument rather than using a paper-based. We have an instrument. We ask an individual, a patient, to stand on that instrument and perform certain tasks. As the individual performs that task, there is automatic recording and measurement of postural outcomes that will be displayed. You don't need to measure with pen and paper. And it gives you now we gave some examples. You see some of the outcomes are, one of the major parameters used is center of pressure, where individuals are been asked to be on the pressure platforms. Then the sway parameters are being measured, such as sway area, sway velocity, sway length, your path or trajectory length. And then those measurements can be made in maybe anterior-posterior direction, in the mediolateral direction, and then you could have a total of it apart from the anterior medial, anterior posterior, medial lateral. So those are some of the aspects we use. And we now said we could have a static or dynamic posturography. In static, an individual is in a fixed platform. You measure the ability to preserve or maintain balance in that situation. But in dynamic posturography, you measure postural reactions or postural responses to changes, in the movement of the surface that an individual is on, maybe rotatory movement, translational movement, or changes in visual surrounding or environment. And we further went ahead and said, apart from this, all these measurements are being done through variation of different situations. We try to explain about 4 situations that we could vary to get our postural readings or outcomes. Talking about surfaces, where we could say we can have different surfaces depending on the level of difficulty. You could have a firm surface, you could have a firm surface, you could have a rough surface, and you ask individuals to stand on that just to see what is the level of postural outcomes across variation in the difficulty of the surfaces being or support surfaces being used. Then we also said we could use another aspect that has to do with vision. We could have an individual performing the task with no visual stimuli, that was eye closed, no visual input, no visual perception. We could also have an individual having various visual interruptions, visual competitions, and we now see how the postural outcomes comes out to be. And then we have a situation whereby you could have even combination. You vary and you combine this situation. Maybe you could say, okay, you have vision closed, no vision, eye closed. Then you could have firm surface, and then you could have another situation that has to do with stance. Maybe you say, okay, with legs together, okay, with 2 legs wide apart, okay, with standing on 1 leg or on paretic leg or non-paretic leg, and then you have your outcomes. Finally, the most important thing we should remember is that in every of this variation, we will likely have the most difficult combination. And that most difficult combination is the combination that is expected to be present in somebody who is apparently healthy. And when you are managing your patient, you are all aiming toward that combination to be you are aiming to get the reading, appropriate reading for that combinations. Once you have that, you have all your aim achieved for managing your patient. So I think if that should be clear.
Okay. Hello.
Yes.
Thank you, sir. So I don't know, maybe my own experience would also maybe highlight a little bit.
Okay.
I have experience working with some of these force plates. I had a training in Germany because I also work with amputees. So I'll just use an instance of, for instance, an amputee, say someone who has an amputation above the knee, for instance, so that for such people, we use such force plates, especially the static posture. So for an amputee, you bring in the person and you say, okay, stand on that posture. There's one we call laser posture. We use this laser lights. So the lights are able to show you, you could visualize on the body of that individual where the forces are transmitting.
Yes.
So you can first bring a client and you say, okay, put your 2 legs on this, stand on this platform, and then you determine the weight of the individual. Let's say the weight of the individual is, say, 80 kg. And then you tell the patient to move one of his leg out of the platform onto another platform that is not being calibrated. So you want to check how much weight he is able to transmit to the intact leg. So let's say the amputated leg is the right leg. and he's wearing a prosthesis, for instance, and then the intact leg is the left leg. Okay, so you are saying stand with the amputated leg on the platform, whereas the intact leg is outside of the platform. So already you have determined the overall weight of this individual. And now you want to determine how much weight is he able to confidently bring onto the amputated limb. Okay, that again gives you their confidence level. So I'm trying to now relate this with, for instance, someone who has a stroke, and maybe want to relate this kind of scenario in a patient that has a stroke. And then you want to know how much strength, how much power, how much exertion, how much pressure is he able to bring onto the weak leg, the paretic limb, for instance. Okay, and there, for instance, if someone stands, the laser light, if someone is able to transmit equal weight on both limbs, the laser light, you will see it running at the center of the body, literally demarcating the body into two equal halves. So where you have the light running through the nose, the tip of the nose, through the let's say the umbilicals, and then go just in between. So in this instance, you could tell that this person is able to transmit weight equally on both limbs. But then in a situation where the weight is being transmitted more, or the load is being transmitted more to one of the limbs, you would see the light tilt more in that direction. And then that also helps in adjustment of the prosthesis in such a way that when the individuals walk, you're sure that in the stance phase, they are able to transmit enough load, and they are confident enough to transmit their weight onto that stance limb, which in this instance is the amputated side. So that again, I'm thinking if it's applicable with your experience, sir. I haven't used it in patients, with intact limbs. I've used it severally on patients with amputation, both lower limbs in terms of below the knee, above the knee, maybe ankle disarticulation or hip disarticulation, knee disarticulation patients. So, but I don't know if that's been applied in the area of stroke, for instance, or all other neurological conditions. So, but that's just my own experience with respect to the static platform. Of course, I've also worked been in a lab, in a gate lab, where they have the dynamic platform and all the machines are there, where you place electrodes on certain points of the body, and then the system is able to, you're going to be seeing the load, the force, the ground reaction forces when the individual steps on a particular limb and all of that. So well, that's just my own way of, relating with what you have said here. Thank you very much, sir.
Thank you so much. At least you have shared it similar to your experience. That's why I said some people had experience of using it already. So thank you so much for the addition. So I have some question in the chat box. In somebody asked if there is a scale to measure posture and balance for stroke and PD with cognitive issues. I think you could still use this post platforms for those people, because the good thing is that in as much as those individuals can obey command, because it's not something that you ask them to recall. If they can obey command and do what you want to do, I think you can still perfectly do it. I'm not sure. I have not seen a specific one that say, okay, this is for those individuals, unless maybe this can be an area of research. If it has not been done, okay, you could say you want to validate it in those people with that type of condition. Perfect. It could be a very nice research. You could take it up as a research if you want to validate postural assessment scale in individual with stroke, but with cognitive issues. Yeah, you can do it. So that's that with that. Then what's the price range for okay, yes, the price range for Okay, no, I can't say, but I once saw a post platform that costs 1,500 euro. So what is you now convert? Well, 1,500 euro. How much is that? I don't know. So you could convert to naira and see. Then okay. Do you want this? You want more explanations on the concept of limit of stability, and then the concept of center of mass, and then base of support. You remember we discussed, we said center of mass has to do with a point where there is distribution of mass equally across the body in all directions. And we usually find it around the pelvic area, usually second sacral vertebra, but we said it usually do changes with change in position for the muscle mass of an individual. But we said sometimes if you hear center of mass and center of gravity, they could be used interchangeably, but the basic common terms that is used between them is the distribution of mass or weight across directions equally. However, in center of gravity, there is dependence on gravitational force, while center of mass, it does not depend on gravitational force. When you talk about center of base of support, we are trying to say this is the area of the body or the demarcation or the surrounding, or you could say outermost or perimeter, or you could say border of the body touching or in contact with the ground. That is just simply base of support. Just the outer part, the perimeter area of the body touching the ground, which is literally meaning the perimeter of the foot area that is touching the ground. So we said we try to discuss the issue of its relationship with mobility and better stability or balance. So I think yes, you can search for the instrument online. Once you search, you will be able to see it, and there are companies that that do sells it. Yes, thank you. So, any other comments? So, in the absence of comment, I think we can take a break, a longer one. I don't know. I'm trying to please just give me 1 minute. Let me get to the second facilitator to know when he's starting so that we know how many minutes we are taking for the break. $30 maybe, or 45 minutes, right? I don't know which one will you prefer. What is the difference between COM and COG? I just explained. I say in COM, there is a point where there is distribution of mass in the body in all directions, but does not depend on gravitational force. The COG has to do with a point of where there is equal distribution of weight in the body in all directions, and this depends on the gravitational force. I think it's clear, right? Or you could simply say it's a point where the gravity seems to be acting on the object or on the body. So I think it's clear, the COG and COM. Just distributions of individual weight or mass evenly in all directions. That point is called center of mass and doesn't depend on gravitational force. But if it depends on gravitational force, then it's COG. So 45 minutes or 30 minutes? Please, let's know your opinion for the break so that before then we could get the second facilitator already. Somebody said 45 minutes. So we're waiting for more opinion. Hello.
Yes, 45 minutes is okay.
Okay.
We should come back 1:32.
Okay. Okay, so we reconvene at 1:45. Thank you so much for listening, and we hope we put the skills used into practice. Thank you all.
Thank you, sir. Okay, thank you, sir.
Thank you.
Hello? Hello? So I've been finding it difficult to join this meeting. I don't know what's the problem with my, is it the problem from my side or from your side? I've been struggling since from the beginning. I'm Dr. Usman Adam Muhammad.
Well, welcome back. I think we can continue.
Hello, good afternoon. Hello.
Yeah, good afternoon. We can hear you.
Okay, thank you. I have to use an external device for the volume. So my apologies for the delay. Then we can now commence the presentation proper. Good afternoon once again. Once again, sorry for the delay. That is beyond my control. Yes. I also like to welcome everyone for this presentation, second part of the presentation, which I'm here to add to what Dr. Jibril Samani presented earlier in the morning. First on the lower limb, the other parts, the trunk and other parts of the assessment will be carried out in the other presentations. Yes. Yes, I don't want to bother us again with definitions, with terminologies. Dr. Jibril Samani has done justice to that aspect of the presentation. I was also earlier in the morning part of the audience during the presentation or definitions aspect of the presentation. But I don't want to just go straight into presentation. Without yes, we need balance in every aspect of life. And what we are discussing today will be balance assessment for Parkinson's disease and stroke patients. Yes. Yes, I said I don't want to bother us again with the definitions, terminologies, and so on. But first of all, what is the importance of this balance in our...
Sir, the slide is not showing.
Hello?
The slide is not showing.
Okay, sorry. Let me go back again. Let me share it again. Can you all see this slide now? Hello? Is the slide visible now?
No,
no, not yet.
Sorry, just give me a second. Hello, good afternoon.
Good afternoon. Welcome back.
Yes. Can we see the slides now?
Yes. Visible and audible.
Okay. Thank you. Let me go to the presentation. Yes. Good afternoon. So, this slides. Hello. Hello, good afternoon.
Good afternoon, sir. You are audible and the slide is showing.
Prof, na ce ko computer ta yi expire ne.
No, it's not computer, it's network, I think. It's network. I think since yesterday, in Nigeria, we have some network issues, no? I think. Some parts, sorry.
What's happening, guys? We can't hear anything. We can't see any slide.
I think it's his network. Please bear with him. I think it's from his network. You know this network.
What if he can share the slide to Hafiz so that he can be controlling the slides?
Okay, let's see. Let's see.
Hello, good afternoon.
Okay, yeah, welcome.
Okay, please, my sincere apologies for.
You understand his network now. Network issue.
Yes, I've been moving around to get the best location for the network, but I think I'm able to get let's say a safe place now. Yes, or better place.
Perfect.
Thank you very much. Sorry once again, my sincere apologies. Like I said, the second presentation will add to what Dr. Samani has already talked about. Yes, balance is important, is very key to management of neurological rehabilitation. However, not just neurological conditions or impairments involve balance assessment. Other conditions also present with impairment that may require assessment of balance. However, this presentation from the poster is limited to only neurological conditions, basically stroke and Parkinson's disease, of course. So, like I said, the first presenter, my colleague, has made justice to the topic, and he has said almost everything. Yes, I was part of the audience earlier in the morning, and I've listened to the presentation. Yes, though we have shared some aspects that I will take also, and I don't want to also bother us with the terminologies and the definitions that he has taken earlier in the morning. However, instead of just going straight into the discussion of balance assessment, we've also decided to discuss some introductory aspect of it. Even though he has gone very far in the discussion about assessment of balance, however, there are some key aspects too, which I've taken from him that I wanted to take through before going into the main presentation. I don't always want to go straight to presentation without just some background or some introductory aspect of the topic. Yes. Like I said, I don't want to bother us with the terminologies and the definition. Yes. However, want to look at importance of balance. Why is this balance very, very important? It is important because it helps to maintain specific postural alignment, like what he has discussed earlier in the morning. That's usually when in when in a static position. Then facilitation of voluntary movement. Transition from one position, from one posture to the other requires very good balance control. However, when one is in either dynamic or static position or posture, there could be some external disturbances, perturbations that will require adjustment to recover equilibrium. So balance is also key. So in a nutshell, these three overall items summarize how balance is important at every situation of the patient. So this is just a summary, but when we look at it, it involves almost every activity that one or patient is involved. Then the assessment of the balance. What are the importance of balance assessment? First of all, just like many other neurological assessments, we'll first of all screen or check if something is wrong or not. So we want to know whether there is a problem or not. That's first thing to check in balance. There's a problem with balance, yes or no? When no, how far can you go to make sure that no is certain? When yes, what other things can you do to find out the severity or find out the cause of the balance impairment? So not just to screen, then to determine the types and underlying causes. I've just mentioned this point. Yes, when there's a problem, you go further to find out what type of problem is it and what are the probable causes of, because this will help us in the management. Then to put all the time when we talk about balance, the first thing that usually comes to our mind is fall. Fall is a very devastating event. When fall, it depends on the patient. Yes, neurological condition, yes, fall is frequent, is common. Yes, we always want to avoid that. We always place our patient, we want to try to place our patient in upright position. But before that, we want to make sure that it is safe to place them on the upright position. Not just the cardio respiratory fitness, not just the yes, the balance is fit enough for that patient to go Yes, I'm back. sorry, fall. We want to make sure that the patients, when we engage them in any position, that they will not be, that they will not fall. And we all know the consequences of falling down, so many injuries, most especially so we know the risk of fall. When there is fall, we always know that there are going to be a lot of challenges with managing that patient. If not that, the patient will go back to get to bedridden position, because might end up being fractured or dislocated or sustained head injury and many other kind of injuries. And at this stage, we problem. So it predicts fall to help direct the type of intervention, because when you're able to know where and why this problem exists, you can direct your intervention straight to that particularized training of balance or fear of falling down again. That is, if the patient has not sustained injury, then gait performance, if the patient is ambulant, of course, limited working tolerance. It depends on which of the system in balance control that is affected. Might use walking aids, which is not a problem, but it might not be needing it if the balance is managed. Reduce walking distance, of course. Somebody need to get involved with some activities and we may not be able to do that because of problem with balance. Abnormal speed, of course. Poor gait performance, movement instability, and so on. Decreased ability to carry out activities of daily living. If somebody cannot reach a certain distance, if somebody cannot move at certain speed, cannot go to work, cannot go and get involved in the basic and especially the instrumental activities of daily living, cannot go out, cannot shop, cannot do many things because of balance, fear of fall. Maybe the patient has experienced fall already and is scared to fall down again, and many other problems. So that will be decreased socialization, that will be effect on relationship with loved ones, with close relations with friends, and decreased socialization at large can be in the form of depression. Yes, because the individual will be isolated and cannot move around, cannot get engaged with social activities, cannot interact, cannot engage in meaningful activities. Then depression can set in. Before going also in as would yes, like I said, these are the consequences, and at the end, it will be psychological impacts and depression as well, and many other things that could follow. Then I also mentioned about utilization. Before going into usage, let's see how much of usage is currently in place. Although the study I have here with me is a study conducted in Canada, which surveyed 369 physiotherapists. 80% of the respondents reported that they regularly assess balance. More than 60% of the time. It means majority of the time, at least three times in a week, they assess balance. And they assess in the domain of sensory systems, cognitive contributions to balance, and reactive control. These are the most regularly assessed systems or aspects of the balance. However, this is a table. Can we all see the table, please? Hello?
Yes, it is clear.
Yes, we can see. Yeah.
Okay. Yes. So we can see in the result, they mentioned that there is a variation in the assessment of balance across orthopedic, neurological, geriatric, and general populations. This respondent give this breakdown that depends on the patient they are seeing, depends on their specialization. They see the patients differently. And the most common tool that was used in this study among the respondents was single leg stance test, then followed by back balance test or scale, then the TUG, time up and go scale. So we can see this is the summary of the result on the table. That's based on practice area, we can see, based on the specialization. We can see that this is a line that when we look at reactive control, for example, I'm jumping some things, but I just want to look at some of the interesting things. We'll just look at the reactive control. We see orthopedics, the usage or utilization is 35%. So that means in orthopedic conditions, in the orthopedic units, they don't usually look at reactive control. But you look at in neurology, has the highest across the specialization or the population that are being managed. You can see we have geriatrics, we have general. Neurology has the highest. When we look at the motor system, yes, we know that orthopedics, they are involved with muscle contraction, muscle strength, and many other things. So it's expected that they will have a lot to assess in motor systems, and that's why we could see 94%. And that's why we could see, sorry, let me use the annotation. We can see 94% for the orthopedics. We can see 92% utilization for neurology, and you can see lesser utilization for geriatrics. So when you look at sensory, you check the orthopedics, the utilization is 53%. But neurology has the highest, which is expected, yes, because since we know that sensory systems are involved also in the balance control, yes. Geriatrics 51% and general rehabilitation 60%. So, and the last item here we have a cognitive contribution, and we can see the orthopedics assess 34. The utilization is 34%, but we see the neurology having up to 74.7%. But we can see geriatrics having higher. Yes, this is expected for neurology and geriatrics, because geriatrics, not just balance problems, but at that stage, they must have, some may have dementia, mild cognitive impairment, moderate to severe, up to dementia, and many other problems with cognition. So what I'm trying to call our attention here with this study and with the summary of the table is that we don't just assess balance, we don't just assess balance, we assess and we find out where the problem is, and we now begin to go directly to where the problem is. But in most of the time, we just make general balance assessment without considering some of these factors. Because when we look at the systems that bring about balance control, which we are going to talk about in a bit. So I also try to check the studies in Nigeria or in Africa, whether there is a study on utilization. Though it's a quick search, it's not a very comprehensive search, just like that of systematic review or meta-analysis or any of the reviews. It's just a simple search I made on Google, and the only study, there is another study, but it's not very close. This study I have is not very close to balance assessment, but it's about utilization of assessment skills, study items or tools for the assessment of balance were included. And this is a study by Okonkwo et al. It's still very recent, 2023. So that's why I decided to include it. There's also another study by USC Okafor, but it's a generalized study and on many other participants. But I feel this is the closest to what I wanted to discuss, because I couldn't find any other study on utilization of balance assessment tools or skills on among stroke survivors or Parkinson's disease. So this is utilization of stroke outcome measures. And there were two outcome measures that were itemized in this study, and together with other stroke outcome assessment measures. And this includes back balance scale and time up and go test. These are the two skills that were included to assess balance. There are other domains that they assess, for example, cognition, motor impairment, sensory, and many other things. But for general assessment of balance, they only include back balance scale and time up and go. So what they found out was utilization. First of all, awareness is low. Then utilization of the standardized stroke outcome measure is low. So this includes also the familiarization and the utilization of balance assessment skill, because it's also part of stroke outcome measures that were included in the study. So this study is more general. Like I said, it's not specific, just like the Ontario study I've just mentioned earlier. So what are those factors that contributed to the low awareness and low utilization? What they found out in the study, this study was conducted in the southeastern part of Nigeria. That is the location in about 2 tertiary health institutions. What they found out, what is associated with the awareness and lack of utilization, first of all, is years of experience. Those with lower years of experience have less awareness and low utilization of this instrument. Then qualification, they found out that physiotherapists or individual or the participants with higher qualification, masters and PhD and other postgraduate qualifications have higher awareness and utilization of this standard outcome measure. So I'm looking at it by extension. This study is not primarily about balance assessment, but it's about general stroke outcome measure. However, I mentioned that some assessment of balance scale or tools were included in the items that were asked for awareness and utilization. So, and they also found that the barriers to utilization of these instruments were excessive workload. Yes, we know we're in Nigeria, and we know that our clinics are usually chock up with a lot of patients, and they are always eager to see the physiotherapist and to leave on time to go back to their respective activities. So this is one of the factor. Then lack of familiarization also. They are not familiar. A number of the participants are not familiar with some of the instruments, and also availability. Probably the availability to have, even though there are some of them are pen and paper instruments, they are not available to be printed for every patient to be used. You know, the cost of paper, the cost of printing and usage, and many other things. So some may be of advanced makeup, so they may need other devices like computer devices and so on, and they may not be readily available. So this is about utilization of balance assessment. So balance control, like I've started talking about, and which Dr. Jibril Samani have also talked about this extensively. I don't want to take us back. We know that balance control involves a lot of other factors, which are the motor, musculoskeletal system, the sensory, the predictive system, and perception, and many other things. This is just a few that are extended balance control system involvement more than this. So that's because I don't want to go deep into that. So this is also another additional information of the previous sets that I just shown. Under the sensory, we have the vestibular, the visuals, the proprioceptive. Under the motor system, we have the muscle strength, we have the coordination, reaction time, and many other things. We have the dynamic stability also, limit of stability, which I know Dr. Sabani has also talked about that extensively. So, yes, these are still the components. Just I wouldn't want to take much time because the last two slides are also similar to this. We have taken a lot of time initially before connecting. So when we want to get into balance assessment, how do we approach the assessment? If we approach it systematically, this will guide us a lot in what we want to achieve, and will also help us in the management. So there are generally three major categories. We have the functional assessment, we have the system assessment, and we have the objective assessment. And this last aspect, objective assessment, Dr. Jibril Samani, the first presenter, Dr. Jibril Samani has talked a lot about this last item. Yes. So, for example, the functional assessment, we have functional risk test, we have time up and go, we have single stance, we have the run back test, we have all of those kind of tests, which they look at only the functional aspect or the function of the individuals or the patient. Then the system assessment. Under the system assessment, we get involved and evaluate the patient, and at the end, we're able to know that this is the system that is affected, and probably will now take our management to that particular system that is shown to be affected. Then the objective, like I said, the first presenter have made justice to the last aspect, so I don't want to take much time into it. So we can concentrate on the functional assessment and the system assessment. So talking about the functional assessment approach, we know that functional activities, most of the functional activities we get involved are balanced and speed dependent. So we'll look at most of these balance tests and assessments that are functional They basically assess speed and similar things. So they are very easy to do. That's why most of the time you see that they are the ones being used, and all the time you talk about balance, you see this functional test coming up. They do not require any expensive equipment. They are usually quick to administer, usually 1, 2, 3 minutes. You are able to administer it and finish up. They predict 4. So under the functional approaches, we have the static balance and dynamic balance assessment, which I don't want to also go into the definitions. So this is just to mention a few of the tests that fall into these two categories. We have the static balance, which we have the one leg stance, we have the run back test, we have the step test, we have the functional reach test. Even though functional reach test is also under the category of assessment of trunk, and also could also fall under assessment of limit of stability. That's where also lower limb can fall in. So that's why I included it. Then tandem stance, and many other tests that could come under static balance. And we have also under the dynamic balance assessment, we have the time up and go test, we have the gait speed and assessment, we have the 10-meter walk test, we have the 6-minute walk test, we have the tandem walk or heel to toe walking test, and many of them. So the limit of stability, I'm just going to. Dr. Swani has talked about this at length, and just why I'm bringing up this slide is for us to know the limits of what our patient can do. This just remind me to talk about this topic. Yes, when we want to use the test, we need to know the normative values, what we're expecting from the patient. Some of these tests were developed for healthy individuals. So we need to know the normative value for patients and for the specific patients we're dealing with. Stroke patient, Parkinson's disease, or any other neurological condition. What are those normative values for those particular patients? And how is it best those patients can do or can best perform those tests, which is also important. I also added the picture of Michael Jackson, like I said, just to remind me, because he usually go beyond the limit of stability that we know, which is, we can see from the picture, this is almost going into 40, 45 degrees, which we know that the limit of stability is less than 10 degrees anteriorly, and posteriorly, laterally, whichever way. And I remember there was also a song by the popular Nigerian artist, P Square, in which one of their song, I think, was it Personally, or I can't remember the name of the song, but they were dancing the steps, and one of the movie actor, was it Aki or Popo, one of them was also trying to follow and dance the steps the way they are doing. And after they did such step, and he tried to mimic and do it, and he fell on the floor. That shows that he has gone beyond the limit of stability. I know people have been asking a lot of questions. I know most of us know about how Michael Jackson usually does that. And, we used to see like he has some special special systems that is able to do things extraordinarily. But it's just some tricks with shoes that are being used to get it hooked to the floor, and is able to do this successfully. So this is just talking about knowing what our patients, what we expect from them, and not going beyond what you could do, because we could grab any other test and say this is a test for balance, and we didn't bother to check that test is supposed to be for military training, military test, and we begin to go and use it on a stroke patient or on Parkinson's disease patient. Then God forbid, problem may arise while trying to assess. So this is just why I brought up these two slides to talk about the limit of stability, to do also the limit of what our patient, the expected numerical values, any other things. So that's why we need to know any instrument or any tool, any scale that I want to use. We need to know first of all that that instrument is valid for that particular patient or group of population. It's also reliable, that not just, we also want to know whether it is used for screening or also to check for stability. Also check for stability. Yes, valid. Hello, I'm back. Sorry, there was a question that I saw on the comment, and I went back to respond. What I said is that the assessment is, I talk about the first one, which is functional approach to the assessment, and which we have static or dynamic balance. So that is the explanation I give earlier on it. So we want to talk about one of the functional tests, which is time up and go test. It is an objective clinical measure, even though this objective is in a quotes, is in question mark, yes. because there are tests we do in the clinics daily, which we define them as objective. And in a real sense, most of the time, these tests are not objective, because the definition of objective and subjective assessment or evaluation goes beyond what we used to talk about as when what the patient report to us is subjective and what the clinician or physiotherapist observe is objective. However, definition of objective is when a clinician or a physiotherapist or any other person makes observation and doesn't require any judgment from that individual, then that's make the assessment or the test or evaluation objective. But when there has to be some decision, so that's why it is objective, because you are just assessing time and you will not make decision about whether it's 3 seconds or 5 seconds. Yes, you could do that, but it's usually a straightforward test. You know that he has started this and he stopped here and this is the time. Yes, but as we go along, we could see some of the things I'm talking about as the subjectivity. Although we say it's clinically objective, yes, because of the time measure that we do, and we'll just get a definite answer, get a definite measure of time. Yes, it assesses speed of mobility and risk of fall. It is widely used. Like I said, the studies have searched and appraised. Most of them, you see time up on go tests involved. It is simple to conduct, yes. So how do we conduct this time up and go? First of all, like I said, we need to know that the instruments we are going to use or we are using, they are valid for the particular patients we are going to manage. They are also the information we are obtaining also, they are reliable. Yes. So it is valid for Parkinson's disease and for stroke patients, also elderly patients, traumatic brain injured patient, and spinal cord injured patient. It's all valid. It's also valid for acute, subacute, and chronic stroke patients. However, it's only valid for subacute and chronic Parkinson's patient, because it is responsive in moderate and fast-working patients and stroke and patient, but it's less reliable among patients with cognitive impairment, and it's not sensitive to early Parkinson's disease. So that's why it's not valid for the acute stage of Parkinson's disease, because it's not sensitive to early stage of the Parkinson's disease. And when there is cognitive impairment, then it's also a challenge, because there is going to be given instruction from where the patient will start. And so there are problems with attention, memory domains, concentration, especially also, and even executive functioning of the cognition. The patient will find it very challenging to do this test. So let's look at how this test is conducted. Yes, I know it's a simple test, but we need to look at its step by step. Yes. First of all, we need a standard chair, which is one of the requirements. And the height for this chair should be approximately 46 centimeters in height. The chair should not be placed against the wall, of course, because it will aid the patient in the sitting up, sitting, standing, and so on. The procedure starts with giving instruction to the patient to stand up and to walk, self-paced. However, sometimes the instruction is as fast as you can, but safe walk, that is not the patient to walk as fast as he can and end up falling. So there is this dilemma of also the instruction. And now we can see the subjectivity coming, because one rater using this could be different from another rater. When another person comes and said, walk as fast as you can, another person said, walk at your safe self pace, the patient will comprehend different instruction and will walk differently to reach to the target and come back. So the instruction is to ask the patient to stand, to walk along 3 meters line or a mark that will be made for 3 meters or 10 feet. And there will be a mark at that 3 meter. The patient will go around and come back and sit. When the patient is back on the seat, then that's when the test is complete and the time will be stopped. So the patient will need to understand this instruction. And that's why I said when the patient is having some cognitive challenges, it depends on almost all the domains, concentration, attention, memory, because he has to remember the instruction. He has to also plan the task. So especially executive functioning, he has to initiate, he has to plan, he has to execute the task, he has to perform it, he has to terminate and sit back, because when there are such issues, the patient will be having a problem. So that is the instruction for the patient to ask him to, you explain the patient to ex-patient, you can demonstrate, you can ask the patient to do the first one, which is just to get familiarization with the test. Then, so what is the expected outcome? You need a stopwatch or any timer that you can use to take the measurement of time. So for the time for an individual takes to stand and get back to sit, that's what individual is going to be, that's what the patient will be measured. And for healthy individuals, it requires just about 10 seconds to do that. That indicates good balance and less risk of fall. Yes. However, for stroke patients, they need about 30 seconds or less. Greater than 30 seconds, then there is a great risk of fall for those individuals. So when we want to engage stroke patients, Parkinson's disease patients, we want to involve them in a mobility task or that involve this kind of test is very, very important. So, however, it has some challenges, which I started talking about right from the beginning, that the retest use error can be high, because I've said it, the patient will do it differently, depend on the instruction. The patient will get used to, will learn how to do it better the moment he does it once, twice, and thrice. So the outcome may come differently. So I've also talked about the instruction that will be given. Then it has another challenge, which is the ceiling effect, that is not able to detect more serious changes, just those little changes in the test or in the impairment of balance. Also, it will not be able to tell you that this is the problem, this is the system that is involved. Then there are a lot of limitations. However, there are some modifications that were made to time up and go. And there is a TUG cognitive and the TUG manual. In this TUG cognitive, there's a task that will be given to the patient to count backward. For example, from 80 to 100 while walking through 3 meters and coming back to sit. Just like the digit span test that we have in MOCA test or in mini mental state examination. You ask patient to count or to make to arrange numbers in a forward, digit span forward or digit span backward test. It depends. So this is just a similar thing. You ask him to count from 80 backwards to 100 up to the time you're able to sit. I know even for healthy individuals to count, just to sit and count from 80 backwards to 100 may be challenging. 81, 80, 81, and so on. So then what is the expected duration? Is 15 seconds, but this is for healthy individuals too. So for the stroke and Parkinson's disease is much higher. Then the TG manual. In the performance of the TG manual, it will involve activity of carrying a cup of water to perform the task. So individual will now have to walk with a cup of water in his or her hand, stand up, walk around, go around the 3 meters and come back and sit. So that is about time up and go and the expectations. Then still on the assessment of static balance, we have tandem stance. This just involve standing and standing with 1 foot in front of the other, just like in the picture shown at the last aspect, just showing the tandem, just like we know in the tandem bicycle or tandem walk, or 1 foot in front of the other. We have a very, very narrow base of support, so that makes it difficult for the individual to be able to withstand that posture. So between 15 to 30 seconds is expected for individual to stand. If an individual cannot maintain that posture for up to 10 seconds, then there is risk of fall, and that patient shouldn't be involved in any mobility task or activity. Just like the first test we have mentioned, or any other test, any other neurological test or assessment we want to do, we want a patient to get involved. We demonstrate to the patient first, and we ask patient to do. Also, the environment that we perform this task also matters. Staying close to the patient, engaging this test in a parallel bar, and or around the wall, or around the table, or around the couch or the bed the patient is lying down, or the treatment is being conducted, is most preferred for safety, to avoid fall, because while assessing that and there is a fall, then there will be a lot of problem in the future trying to get that patient into upright position. So another test we have is step test. So this step test is usually the staircase, or the step box that we have in our exercise therapy labs or in the gymnasium is used for this assessment. And when we check in our clinic, the standard step box should on one side be up to 7.5 meters high, 7.5 cm high, sorry. It's not by chance. Maybe if we go back to our clinic, we should check. We'll see that on one side of the step is higher than the other one, but the one with the higher, with the most height is around 7.5 centimeters. Yes. So in this test, you ask the patient to stand on one limb and to be stepping on the stair, or on the step, to be stepping as fast as he or she can. Then you count how many steps that individual is able to do in 15 seconds. So if the patient is unable to stand unsupported, then that patient cannot do that test and the score is 0. And there's also risk of course, we know that patient cannot even stand. So risk of fall is a must, or it's something that we expect. So for non-paralytic limb, we have up to 15 seconds, 15 steps. So that's about a step per second. Then paralytic side, we have 10 steps, which is a bit slower. So if an individual is not able to do that, then there is a risk of fall also. This is also a test that most times is used in gait rehabilitation or when weight shift is required in the training, especially in stroke patients. Yes, especially also in the management of misstance and also some aspect of the swing phase. Yes, the management of gait. Then we have also the very common or popular run back test. How do you conduct the run back test? We ask the patient to stand erect. So patient will stand and we start with the eyes open before going into the eyes closed. Just ask the patient to just stand with arms by the side. So the patient is able to stand up to 30 seconds. Patient has a good balance control, of course, but this also can be tested further by closing the eyes of the individuals of the individual, which will make the test more challenging or more difficult. Apart from eyes closure, the surface also can be modified. Can start with a hard surface or hard floor, then a compliant surface can be involved where the surface is making it challenging for the patient. For example, just the mat foams mattress in the gym could make it more challenging, or any other surface. Then modification could be with the position of the upper limbs, taking them up or down, and so forth. So this also check for the static balance. Yes. Then one leg stance. The patient is instructed to stand, then to stand on one limb, the hands on the hips, the eyes will be open. Yes. So the participant must stand on, should be, there should be no assist holding something. The individual should be able to do it within a few seconds, 5 seconds. However, this test was developed for military tests. Yes. So that means it's for healthy individuals. And how do we mark if a patient is unable to perform the task? If the limb that was held up touches the floor or touches the limb that is holding that the individual is resting on or standing on, or the arms leaves the hip, that is trying to deploy a certain balance strategy, maybe the arm strategy to maintain the balance. Yes, so that means the individual has failed the test. So if he's able to maintain that up to 5 seconds, then it's expected that the individual has a good balance, but this could be extended up to the maximum of 20 seconds for stronger patients or stronger individuals. But 5 seconds is just okay to know that the individual has a very good balance. So it has some disadvantages that is only static balance. Only one task is assessing, just like the other tests. Yes, for the dynamic, yes, it involves the static and dynamic, but most of the tests that assess static balance is only one task, only static balance. Then it doesn't show also what problem, just like the other tests also. In the functional, most of the functional tests, like I said, they don't show that this is the exact problem. This is the exact component of the balance that is impaired or that is a problem. Then then the physiotherapist will be able to go and tackle such area. So this is one of the limitation of the functional assessment approach or the functional assessment test. We have also another test, which is the Fukuda test. This Fukuda test involves patient or individual standing. Then the instruction is to ask patient to stand and to make steps. To make steps on same spot, just like marking time in the military, maybe as I don't know if there's any military or uniform individual, if I've said the right term. So just like asking the patient to make steps just in the same spot without moving, to make steps with the two limbs, not like the step test that we had using the stepping box, but this one is just to make step or to match in the spot marking time that we did in the NYC service or those in the military. Okay, thank you. A military just responded to me that the term is correct. So you ask the patient to do 50 steps, and after the completion of course, the eyes will be closed. Sorry, there's an instruction missing there. You ask the patient to close his or her eyes and make those steps up to 50. Then you ask the patient to open his eyes or her eyes. And what you observe is there will be a little bit of rotation of the body. If the patient is facing a certain place, after opening the eyes, they'll observe that they have deviated to the side. So up to 30% rotation is okay. But when an individual rotates more than 30%, of course, then there is a chance of, or it indicates balance impairment. It means there is a problem and there could be a risk of fall. Then the functional reach test, which I don't want to dwell on it, which I've mentioned earlier in the presentation that Professor Rufai will take care of that when looking at the balance assessments of trunk control. So I think I just brought it up here because of the limit of stability, and there are different ways to assess it. Currently, there are some modification. We have we know the forward reach, but we have the lateral reach now, and we have also the posterior reach and so on to assess that. So just want to skip that. Okay, I have another military also that's made a comment. Yes. So the test individual will walk on a narrow base of support. Such is similar to the tandem stance, but at this time, the individual have to move, have to be involved in mobility, has to walk up to a certain distance, heel to toe. So you count the number of errors that the person or the patient has left those lines, then it's showing a risk of fall. However, all these tests, when we are assessing, because the balance assessment were divided into different sections. But we know that we start from lying position up to upright position, up to walking to assess the balance. So it's not just random. You pick and say, want to test the tandem walk test, for example. We have to make sure that the patient can come from sitting to lying, can maintain sitting, from sitting, can transition to standing, then from standing to, and so on. Yes, the tandem walk test is done with the eyes open, not the eyes closed. Yes. So even for healthy individuals, when maybe our military brothers and sisters maybe are exception, but for even healthy individuals, when you try to do the tandem walk test, it's a bit difficult. So to talk of patients, yes. So with eyes open. So one of the challenges with this functional assessment is I've said in some of the assessment, while presenting some of the tests, that they are subjective. And I believe now you may, and you may not, you may agree with me that even though we call them objective, many tests we call them objective, but maybe do some of my explanation here and due to some of our background knowledge, we know that they are not objective, so they are subjective. And that's why we need to look at the objective test or assessment that Dr. Samani has talked earlier in the morning, which are precise and definitive. You will know which problem, and you'll be able to quantify it, and you'll be able to know the little change that occur, whether it's got worsened or whether it has improved with the treatment or with the management. So the absolute effect, of course, I've mentioned, like the time up and go and many of them, that those little changes are difficult to determine when using this functional approach of assessment. They are usually not responsive to small measures of progress or deterioration. Then they cannot specify what type of balance problem a subject has in order to direct treatment. Of course, we'll know whether it is sensory problem, whether it's a motor problem, whether it's proprioceptive, is a perceptual problem, or is a vestibular problem, or what kind of problem is. We won't be able to know at most times using this functional approach of assessment. We only know that, yes, balance is impaired, yes, and when we give treatment, we will see that it's improving or not. One of the challenges also with balance assessment is with many neurological assessments. Many neurological assessment is most of the tests are also treatment. So when you begin to test too much, it's like you are treating the patient. When you come back, you see that you are not only testing, but you are treating the patient. That is a challenge, especially for when you are conducting researches, when you are conducting especially RCTs, That's where sometimes you have to mention some of the things that affect the validity of the study is when you have testing also that comes with treatment together. Yes. So then the objective assessment. Yes. This objective approach or assessment usually differentiate among types of balance disorders. Yes. And it can determine the underlying sensory motor mechanism constraining the balance control or any other system that is affecting this, and that's what I've mentioned. That's what we had in the morning. Then, apart from the objective, we have the system approach, and that is what I've mentioned earlier at the beginning of the presentation. We have the functional approach of assessment, we have the system approach of assessment, and we have the objective assessment approach of assessment. In the system, yes, is what was observed is that this functional assessment is very, very limited. So some of these tests that come into existence begin to some of these tests. Sorry, I check questions and respond immediately. That is why I have to pause sometimes. Yes. The system approach that is at the middle, it was based on the observation of the limitations and the challenges of this functional approach assessment. Then that's when some of these tests that I've mentioned, for example, these two, they combined many other tests. For example, one test has functional reach test, has mobility test, has this different test, and different tests involved in strengths, in sensory assessment, combined together. Then overall, after completing the assessment, you'll be able to know that this is the system, a sensory system. Okay, let me go and focus on the sensory system and rehabilitate it. Then, or is the motor, or is the coordination, or it is the reactive control, then I should go and focus on those things. That is all to talk about in the system assessment. I also want to apologize that I'm unable to bring this system approach to the slides because of some factors which we have discussed with the Ray institutions, and I've explained to them why, the reason, and I want to tender this apology that during the next presentation, the practical sessions, we're able to demonstrate most of these tests I've mentioned, and we can see them practically, and also bring up the other components, the system approach of the assessment. And I've also forgot to mention that during the time of and go assessment, there is one of the things that made it also subjective is when a stroke patient conducts time up and go, there is a difference in when the patient turns using the affected side or when he turns using the unaffected side. So that also depends, that when you subject stroke patients to TUG, does he turn using the affected side, or does he turn using the unaffected side? There's going to be a difference, marked difference in the time that the patient will be able to complete that task. So with this, somebody asked question about slide. I'll share this the slides. There is no problem. After the presentation, I'll send it to the Ray Rehabilitation Institute. And with this, brings to the end of this short presentation, because like I said, Dr. Samani has taken almost everything in the presentation. We have discussed earlier with him, and he said, okay, you take most of part of it, and I'll take the practical session. Unfortunately, I learned that today is not when the practical session will be taking place, and so that's why at some point I have to stop the other aspect. That let me just come and highlight some of these things. Then when is the practical session presentation or time that was allotted, then we can take all the practical session, including additional information. Thank you very much. And if you have any contribution or observation, we can discuss further. Thank you very much for your time and for your patience. And thank you. Dr. Jibrin Samani?
Yes, I'm waiting whether they will have some comments.
Okay. And to the military personnel, thank you for the responses, for the prompt responses. Thank you very much.
They are asking for slides.
Yes, I'll send it. I've mentioned towards the end that because there was a question about slide and I responded, I'll share the slides with the Ray Institute, and they will send it to the group. Or I don't know how they are going to send it, but then I will send it, inshallah. Thank you very much.
Okay, I think in the absence of comments, we thank everyone for participating, and the next session will come up the next Saturday, and then the follow-up hands-on sessions will also follow subsequently. Thank you so much. I'm wishing you all the best. Bye for now.
Okay, bye. Thank you. Thank you very much.